thank you everyone for joining. My name is Courtney Coleman. I'm from the European Lung Foundation. Thank you all for coming and joining the conference. I'm delighted to hand over now to our conference hosts, Hilary and Stefania. Over to you, Hilary.
Good morning and welcome everyone to the 2025 Severe Asthma Patient Conference. I'm Hilary. I'm a severe asthma patient. I'm originally from the United States, but I'm now living in France. On behalf of the European Lung Foundation and SHARP, the Severe Heterogeneous Asthma Research Collaboration Patient-Centered, I'd like to welcome you all to the 2025 Severe Asthma Patient Conference. We have an international audience today, so before we start, I'd like to draw your attention to the simultaneous translation option. You can either use the Wordly app in Zoom, or you can go to the chat right now, and that will take you to a site where you can choose your language and be able to read the automated translation alongside the conference page. We hope this tool will be useful, but it's not perfect, so just know that. But it should be very helpful if you would like this in a language other than English. So I am delighted to be co-hosting today's conference. I got involved with ELF and SHARP after I attended the last severe asthma online conference. When I logged in that morning, which was almost 3 years ago, I wasn't sure how long I was going to stay. Maybe some of you feel the same way today. It was a Saturday, just like today, and we had plans as a family. But as soon as the conference started, I couldn't believe how useful and practical it was and how high level the content was. I really appreciated that the speakers had faith that we as patients could follow along with high level content about asthma, its causes, medications, and I wound up staying the entire day. And I loved it. And I learned so much and I connected just with the community so much that I joined the patient advocacy group right away afterward. And then eventually I became the patient co-chair of SHARP. And now I spend a lot of time working on my personal areas of interest, which are allergic asthma, adrenal insufficiency, which I have from years of prednisone use. Maybe some of you on this webinar have that as well. And I'm also very interested in small airways and the role they play in severe asthma. So I love that I can take practical action on these things. And I hope some of you today will join the patient advocacy group as well. We'll have more information about that throughout. So please keep an eye out for that. Co-hosting alongside me is Dr. Stefania Principe, and I now invite her to share a little bit about her background.
Good morning, everyone. I want to say it is an honor for me to be the chair with Hilary of this very important conference. I am Stefania Principe. I am an Italian respiratory doctor that moved to the Netherlands, and now I'm living in the Netherlands and working as a postdoc and pulmonologist at the Amsterdam UMC. My research focuses on precision medicine, mainly in severe asthma. So I have the goal to find a way to target the right treatment to the right patient. So thank you very much. Really glad to be here. And I hand over to Hilary for the continuation.
Okay, great. So today's event is organized by the European Lung Foundation and the Severe Heterogeneous Asthma Research Collaboration Patient-Centered, which is just a mouthful, so we're going to call it SHARP from now on. But a lot of the sessions today will talk about SHARP and how patients can get involved. For those who don't already know, the European Lung Foundation is an organization led by patients. They work across the globe to bring patients, the public, and healthcare professionals together to improve lung health. ELF focuses on advancing diagnosis, treatment, and care for lung conditions. And one way they do this is through conferences just like this one, where patients can learn more about their condition and ask questions directly to experts. It's not just about learning from the professionals, though. Experts can also learn a lot from hearing about our personal experiences, all the patients that are on this webinar, and what it's like to live with our lung conditions. So since 2021, ELF has been hosting these patient conferences, And many patients, along with their families and friends, have told us how much they've learned and how the events have made them feel less alone. It's also a great opportunity to see how dedicated the healthcare professionals are to improving care and treatment for all of us. We also recognize that there are many health professionals in the audience today who are eager to deepen their knowledge and enhance their ability to support their patients. So thank you for being here today and welcome. I would also like to thank the huge network of patient organizations and healthcare professionals who helped spread the word about today's conference. I hope you'll find today's conference helpful and enjoyable. After the event, we'll send out a survey, so please share your thoughts with us, and thank you so much for being here today. As I mentioned, I'm a member of the ELF Asthma Patient Advisory Group who have helped to organize this conference alongside our colleagues from SHARP. If you're interested in joining this patient advisory group to help improve awareness and treatment for asthma, please get in touch. There is going to be a post in the chat with a link and an email address that you can email to find out more. We know that severe asthma affects tens of millions of people worldwide, and that's what makes conferences like this one so important. It gives us all a way to deepen our understanding, explore ways to manage the condition and the comorbidities, learn about treatment, and all the latest research. We were amazed by the incredible response to today's conference. We have over 573 participants registered from over 73 countries, which is amazing. If you're on social media today and you're posting about this, please feel free to share your thoughts and to tag the European Lung Foundation in your posts. We also want to know how you're feeling during the conference. Sometimes it can be hard for us to tell what's resonating with people, so don't hesitate to use the reaction tool to show us if you love something in particular or you're particularly excited about something. Okay, now I'm going to hand it back over to Stefania.
Thank you, Hilary. So, I'm giving you a bit of an explanation of the program. There are two main sessions in this conference, and Hilary and I will be chairing throughout. In each session, we will introduce the speakers, keep them to time, and coordinate questions to ask at the end of the session. Time is allocated for questions after each session. We are fortunate to have a highly knowledgeable speakers who are leaders in the field of severe asthma, deeply committed to patient engagement. They actively encourage patient involvement in their work and welcome your input. We also want to learn from people living with severe asthma. So we'll be hearing directly from two patients in our advisory group about their lived experience. This event is a great opportunity to connect also with others. We want it to be as interactive as possible, so please say hello in the chat, share where you're joining from, and ask questions in the Q&A box, which is at the bottom of the screen as we go along. We know there may not be time to answer all of your questions during the speaker Q&As. So we are very lucky to be joined by two leading severe asthma experts who will be busy answering your questions behind the scene. So I want to give a huge thank you to Sven-Erik and Elsa for all your support. There is no such a thing as a silly questions. Really, feel free to ask anything. Please just note that our speakers and Q&A supporters can't address personal cases or give direct medical advice. You can like questions you'd most like answered by clicking the thumbs up icon, and this helps bring them to our attention and reduce duplicate questions. So our goal is for you to gain the knowledge you need, and we hope you take a lot out of the day. In a few moments, we will kick off the program. So the first session will look at basics of severe asthma and outline how common comorbidities affect severe asthma. We'll then have a short break before going on to explore current research and new treatments. So before finishing up, Hilary will give a short introduction to our severe asthma research collaboration and how you can get involved. There are just a few practical tips for you to note. Of course, this is a webinar style event, so attendees can only see the speakers, panelists, and hosts. Participants are muted, but you can participate in the chat and through the Q&A. We are recording the event and the video will be made available on the ELF website after the event and YouTube channels afterwards. Registered attendees will get an email to let you know when the recording is ready. Please write your question in a Q&A board. We will try to answer as many as we can in the time that we have, and we will try to get answers from the speakers after the event to any unanswered questions, and we will put this on our website for you to access after the event. Some of our speakers have included polls in their presentations. We're going to try a poll right now, so you can see a bit how it works. So for this poll, we would like you to say how much knowledge you have about severe asthma. And you can vote the poll from 0 or 1 where you have completely no knowledge to 10 where you have a lot of knowledge about it. So I give you a few minutes to answer to the poll. Okay, thank you very much. We have quite a big distribution. I can see that the highest percentage has a knowledge of 7, which is a good knowledge, but we also have some of you that has a lower knowledge or higher knowledge. So I really hope that this event will help you gain more knowledge on the disease or clarify some aspects that you might already know. Thank you everyone for voting, and I will now hand it over to Hilary again.
Thank you, Stefania. We're ready to get into our first session. So I just want to go ahead and introduce the speakers. The topic is going to be kind of the basics of severe asthma, quickly, a quick overview of that, and then moving right into comorbidities. This is a topic that was picked by our patient advocacy group because it is so important and something that we often don't get enough coverage of in our doctor's appointments. So I just wanted you to know this was a very patient-led decision to start the day off jumping right into comorbidities. So it gives me great pleasure to introduce our first speaker, Dr. Ramesh Kurikularachi. Ramesh is a professor at University of Southampton, an honorary consultant in respiratory and general medicine plus allergy at University Hospital. He led the regional difficult asthma clinic at Southampton for 11 years and turned it into a multidisciplinary team. We will have a question and answer session with Ramesh after all the talks in this session, and we're so grateful to him for being with us today. I'm turning it over to you now, Ramesh.
Thanks very much, Hilary. I will just try and share my slides. Great. Okay, well, good morning, everybody. It's a great pleasure to be invited to speak again at this prestigious conference. And this morning, what I'm going to do is consider severe asthma from a different angle by looking at it in the context of the whole person with asthma. So I'm actually going to particularly focus on the other health problems experienced by people with severe asthma. And this is an outline of what we'll cover in my first of 2 talks, actually, this morning. We'll look a little bit at the nature and the burden of severe asthma, and then how that combines with other health conditions or comorbidities, and the construct of a difficult breathing syndrome as a model by which to appreciate that. And then we'll look at the impacts overall of comorbidities and severe asthma and how they affect people suffering with severe asthma. And then towards the end of this talk, we will look at how comorbidities might be regarded as treatable traits, things you can do something about in severe asthma. So what is asthma? Well, asthma is a chronic disease of the airways in the lungs, and it arises from a combination of complex processes within the airway walls. And these can be categorized into 4 groups, as you see in the center of the screen here. Inflammation, a twitchiness or hyperresponsiveness in the airways, structural changes, what we call remodeling, and increased mucus production. And as a consequence of these processes, the air passages in the lungs narrow down, as you see in this picture on the left-hand side of the screen. And that then leads to the difficult symptoms that people with asthma experience, such as cough, breathlessness, chest tightness, and wheeze. So how common is asthma? Well, actually, it's very common. Over 300 million people worldwide have asthma. And it's particularly common in Europe. So it's appropriate here at an ELF, European Lung Foundation conference, that we're focusing on asthma. It's estimated that 6% of people in Europe have asthma, and in some countries it's much higher, such as the UK. And asthma places significant burdens, both at a patient and family level and for wider society. So for the patient and family, there's the burden of carrying chronic symptoms, needing to take regular medication, not infrequently experiencing side effects from the medication, sometimes getting acute asthma attacks or exacerbations, and then becoming dependent on healthcare support and carers, and then experiencing impact on work, lifestyle, and quality of life. And then for society, there are the costs of treating the disease in terms of the medications and providing both chronic and acute healthcare resources. And there is the very real burden also of lost productivity because people aren't able to contribute to society because of the severity of their asthma. And much of that burden that is carried by people with asthma falls in a subgroup of people with more severe disease. And this accounts for about 3 to 10% of all people with asthma. And this more severe asthma is much more common in women, and it increasingly imposes significant symptom burden and impairment on that individual. And it also exposes them to the side effects of treatments that they end up taking, particularly treatments like oral steroids. And it has high healthcare impacts. And it's estimated that severe asthma accounts for up to 60% of the economic impact of asthma. So these burdens I showed you on the last slide are particularly pronounced in the case of severe asthma. Now, over the last half a century, a huge amount of research has gone on to understand the biological processes and the cellular players that underlie the development and ongoing nature of asthma. We now know that there are a range of cells and messenger molecules that orchestrate those pathways. And you'll hear healthcare professionals and researchers talking about asthma in terms of type 2 and non-type 2 inflammation to overview that categorization. And over the years, we've developed a range of treatments to target these kind of pathways. And here you see a stepwise management plan to address asthma management. And this is this kind of strategy that your healthcare professionals will be following in their management of your asthma. So as the disease gets more severe, they escalate the treatment to stronger and stronger treatments. And at the top rung of this ladder lie the biologic treatments, which have been developed to target particular players in that asthma pathway, cells and cellular messengers. So if in your healthcare system, your healthcare professional has access to biologic treatments and you're having asthma exacerbations despite being on the right optimized conventional treatment, you are showing the markers that these biologic treatments target, and you're taking your treatment, it can become a simple checklist for your healthcare professional. Tick, 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 and go to biologics. And for us, biologics have actually proven to be a very effective treatment, and we'll hear more about that later in the morning. So with biologics, have we now sorted severe asthma? And there's a huge temptation to say yes, but I would say to you the answer actually, sadly, is no. And one reason for that is that patients with severe asthma have many other health problems. So what we see is that patients on biologics may still have very complex illness models despite the biologic therapies. And we call these other health conditions comorbidities, as you see in the picture here. And one way of understanding the association of severe asthma with comorbidities is to adopt a model such as the difficult breathing syndrome. This is something we've developed at Southampton. So when I see a patient referred into my clinic, as I did last Monday, and I'll see again this coming Monday, they come to me with a description that they've got severe asthma. Can I help them? So I embark on a process of characterization to find out what is going on. And when I do that, I will find that they may have features like allergy, what we call atopy. They may have particular patterns of inflammation in the airways driven by cells that we call eosinophils or neutrophils, and we might broadly call them T2 high or T2 low. They may have poor lung function, and they may show particular patterns of poor lung function, like what we call small airways disease. But we also find that they may have other lung problems, like fungal allergic airways disease, bronchiectasis, or COPD. They may have other issues such as aspirin sensitivity or sulfite sensitivity. And then moving outside of the chest, they may have conditions like nasal problems, rhinitis and nasal polyps, breathing pattern disorder, inducible laryngeal obstruction, gastroesophageal reflux, obesity. They may be unfit. They may have psychological comorbidities. They may not be doing the thing I really want them to do at their healthcare professional, which is to take their medications correctly. They may be doing things I desperately don't want them to do, like smoking. But they may also be taking very toxic medications to try and control their asthma, like oral steroids, steroid tablets, and experiencing side effects of that. So they may have conditions like adrenal insufficiency, thinning of the bones, or osteoporosis, or cataracts. And then in a proportion of people, their job might be relevant as well. So you can see this isn't just a patient with severe asthma. This is a patient with a huge amount of things potentially going on. And that's what we call the difficult breathing syndrome. And to really manage them properly, we need to take a whole person viewpoint. And these comorbidities, these other health conditions, are very common in patients with severe asthma. Most patients have at least one additional comorbidity on top of their severe asthma. And in fact, our research suggests that patients typically have 3 or 4. This is data from Southampton, from our studies that we're conducting here. And you can see here that 2/3 of patients have rhinitis. A similar proportion have gastroesophageal reflux. About a half have breathing pattern disorder, obesity, or psychological comorbidities. And there are a range of other conditions that are still pretty common. So can we get a handle on how comorbidities impact severe asthma? So this is a really busy slide, but it comes from a very important study, which is the International Severe Asthma Registry. So this is a big study, 12,000 patients from 22 countries. And what they did in this study was they assessed them for 30 other health conditions or comorbidities, and they grouped them into 3 categories. Potentially T2 related, which refers to the type of inflammation that might be driving their asthma and those other health conditions. What they call potentially oral steroid-related comorbidities, and what they called potentially mimicking or aggravating comorbidities. Now, this is a slightly artificial construct, but it gives us a useful framework with which to start to understand the problem. And just look at this picture at the bottom here. See these 4 columns, and focus on these dark blue lines. And those segments tell us the proportion of people in these categories who have no comorbidities. So this is the whole population, and these are the 3 subgroups that you see here. And the take-home message is it's a minority of patients who have no other comorbidities. The vast majority have 1, 2, or even 3. So these are very common. And what they went on to show in this study is that many of those individual comorbidities I showed you on the last slide are associated with what we call adverse asthma outcomes. So things like ending up on daily prednisolone, having frequent asthma attacks or exacerbations, worse lung function and poor asthma control. And what they also showed was that it wasn't just the individual comorbidities, but was their combination, the head count, the number, was also often associated with these adverse outcomes. And what I'm going to show you over the next few slides are some broad headlines about how comorbidities have negative impacts in severe asthma. So this is information from a study done in Singapore, where they studied patients referred into their severe asthma clinic and followed them up for 5 years. And reassuringly, 3/4 of the patients got better, but a quarter didn't. So they asked the question, why did those people not get better? And they looked at baseline predictors when patients came into the clinic that might determine long-term poor asthma control. One factor was the severity of the disease at the outset. And this is the ASSESS score, which is a combination of factors that can represent asthma severity, and it gives you a single score figure on the degree of severity. So if your ASSESS score, your asthma severity at baseline, was worse, it was less likely that you would achieve good control over the subsequent 5 years. But look at this. There were two health conditions: bronchiectasis, which is a condition where you get a widening and a thickening of the airways and significant phlegm generation into the lungs, and gastroesophageal reflux, where you get acid spilling back up through the gullet. If you had those conditions at baseline, you were much less likely to attain good long-term asthma control. Now, I mentioned biologics and how they've really helped us. And one of the key goals now with biologics is to achieve something called remission. And remission means really trying to show that you can get rid of the disease to all intents and purposes. And we measure remission by the lack of needing oral steroids, the absence of asthma attacks or exacerbations, minimal symptoms, and good lung function. And what studies are showing is that you can achieve remission in about 1 in 3 patients with biologic therapy. And this study here took an overview. It looked at about 25 studies of remission in asthma to find out what drives it and what blocks it. And they were particularly interested in what blocks it. So if you had worse and longer standing asthma at baseline before you went onto your biologic, you were much less likely to achieve remission. But also, if you had a range of other health conditions at baseline, you were much less likely to achieve remission. So depression, obesity, COPD, obstructive sleep apnea, and osteoporosis. Now, we're very poor at recognizing the relevance of quality of life when treating health conditions as healthcare professionals. But when you look at comorbidities in relation to quality of life, you see this rather disturbing relationship. So as the comorbidities go up, the quality of life goes down. And this is exemplified in this UK study, which looked at the impact of comorbidities on quality of life in severe asthma patients. And they showed that baseline quality of life was associated with having more comorbidities, and particularly those that they blamed on oral steroids, like obesity, psychological comorbidities, and osteoporosis. And worse quality of life was associated with worse asthma outcomes and more steroid needs. The other thing that we're not very good at thinking about in our healthcare are costs. And this is a large study from Canada, nearly 20,000 patients, where they looked at the cost of treating severe asthma compared to non-severe asthma and also compared to no asthma. And what they found, perhaps not surprisingly, is that the cost of treating severe asthma was significantly greater than the other two groups. But interestingly, what they found was that 50%, a half of the cost of treating severe asthma, came from the other health problems that those patients had, their comorbidities. So what we can gather now is that comorbidities are highly impactful on patients with severe asthma. But what can we do about it? And one way to start to think about that is to adopt an approach called the treatable traits strategy. And this was developed about a decade ago to encourage healthcare professionals to focus on personalized management of patients. So to be a treatable trait, the condition has to be clinically relevant, identifiable and measurable and treatable. And broadly speaking, the treatable traits are grouped into 3 categories: pulmonary, related to the lung; extrapulmonary, coming from outside of the lung; and behavior or lifestyle. I'm just going to show you some information from 2 studies to illustrate the relevance of treatable traits. This is quite a landmark Australian study. And what you see here is that this graph is telling us that treatable traits are incredibly common in patients with severe asthma. On average, the typical patient had about 10 to 11. And a significant number of those treatable traits came from outside of the lung, other health problems. And what this graph here is showing us is that as the number of traits goes up as you go along the horizontal line, the quality of life is getting worse. So a real big impact from the treatable traits. This is the Dutch study where they looked at treatable traits in patients referred into an asthma service. And they found that typically patients had on average 3 treatable traits. And interestingly, fatigue was the commonest trait. So if you do have severe asthma and you're feeling tired, you're not alone. It's very common. And they showed that there was a significant association of treatable traits with worse asthma control and worse quality of life. So in summary, what we see is a picture that severe asthma is very significant. It imposes a high burden on the individual patient, their families, and healthcare providers. Biologic treatments offer us a major way forward to treat that, but many patients with severe asthma continue to experience major health problems despite biologics. Comorbidities are very common and highly impactful in complex asthma, but they're treatable traits, and I'll explore that with you in more detail in my second talk in a few minutes. So I'm going to wrap up there, but I've got a couple of adverts for you. If you're a patient and you'd like to take part in online research about that concept of asthma remission, we have a study from Southampton that's being rolled out globally, and there are some QR codes. I'll show this again at the end of my second talk. And if you're a healthcare professional and you'd like to learn more about asthma and allergy, I am just signposting you to our excellent online MSc allergy course at Southampton, which you're welcome to explore. I'll stop there.
Thank you, Ramesh. As you can all see as our participants, we're so lucky to have Ramesh in our SHARP network. He is so knowledgeable and so wonderful and managed to squeeze a lot of information into a short period. We're now going to take a little break, as Ramesh said, to hear from a patient. I'm delighted to introduce Ricky Mueller. Ricky lives with severe asthma and a number of other comorbidities and will share their experience of navigating multiple health needs and advocating for their health needs. So Ricky, I'm going to turn it over to you.
Thank you very much. Right, my name is Ricky and I'm 60 years old. I've lived with respiratory problems since I was born and have asthma, bronchitis and a number of comorbidities, including various allergies and dermatological conditions. My asthma made school difficult and I struggled to take part in sports and got bullied as a result of it. I missed a lot of school due to bronchitis because that obviously had an impact on my education. It wasn't until adulthood that I actually started learning about my conditions, and that made a huge difference on how I managed them. I started to learn how my illnesses functioned and why my treatments worked. And the more that I understood, the more confident I became in asking doctors the right questions and discussing my treatment options. The knowledge helped me get better, more appropriate care. And I got referred to specialists and given access to pulmonary rehabilitation. And my medications got adjusted and refined, and each change made a noticeable improvement. We're all different, and even people with the same diagnosis experience it in many different ways, and what works well for one person may not work well for another. Medicine isn't a one-size-fits-all, and if a drug doesn't suit you, you have to speak up and ask to try an alternative. But always share with your doctor how your treatments make you feel, both physically and emotionally. Understanding your medications and your body helps you make the most of your care and can also help you when requesting referrals to specialists when needed, such as a respiratory nurse or a hospital doctor. Pay attention to your body and how it reacts to stress and air pollution and even your diet. There's many theories about food and lung health, and not all of those are proven. Still, you might find or notice that certain foods or drinks make you feel better or worse. And when this happens, I personally adjust accordingly. And always stay hydrated, as keeping your lungs as clear as possible can help reduce infections and make your breathing easier. Sinus problems and seeing the bigger picture. I've talked mostly about my lungs, but I've also learned that other conditions like my sinus and heart problems can affect my breathing too. When my sinuses were inflamed, my lungs suffered, and when my heart wasn't doing well, my breathing got worse, and the reverse was true. So I now try and look at my health as a whole, not as separate illnesses, a holistic view, which helps me understand how everything interconnects and helps my doctors see the full picture when treating me. Every time my sinuses flare up, I get facial pain, swelling and tenderness around the cheeks and eyes, a blocked nose with thick yellow or green mucus, a reduced sense of taste, a high temperature, a sinus headache and toothache can occur, But for me, the most debilitating thing is pain behind the eye, probably due to pressure. The changes I mentioned in mucus viscosity, the thickness, and the colour reflect the fact that I'm experiencing an infection. Sinus infections can either cause lung infections, or lung infections can lead to sinus infection. They are very much linked and therefore of concern to an asthma patient like myself. Typically, a viral infection of the upper respiratory tract, like a cold or flu, can cause swelling in your nasal passages, and this swelling may block your sinus passages, trapping mucus and leading to a secondary bacterial infection in your sinuses. The bacteria from the sinus infection may spread to the lungs and cause an infection in your lungs. Your blocked nose can cause mouth breathing, which lets unfiltered air into your lungs, bringing dust and allergens that can trigger your asthma. So that one of the key lessons that I've actually learnt is the fact that knowledge is power. Learn as much as you can about your health conditions. The more you know, the better you can communicate with your doctors and the better care you'll receive. It's equally important to have a clinician who listens to you. Not all general practitioners fully understand complex respiratory conditions, and not all are good listeners. So if you don't feel heard or supported, don't worry about changing your doctor. Always explain clearly how your illnesses affect your everyday life, your energy levels, your quality of sleep, your ability to move about, as doctors can only help if they understand the real impact on you. My final thoughts are that I hope sharing my brief story of one of my main comorbidities gives you something to think about. Managing a respiratory condition, particularly when you experience a number of comorbidities, isn't easy, but by understanding your illnesses and working with your doctors, it makes a big difference. Thank you for listening, and I hope you enjoy the rest of today's talks.
Thank you, Ricky. That was a wonderful reminder from a specific patient point of view of exactly how comorbidities can play a role in exacerbating asthma and contributing to a vicious cycle. So we're going to go back to Ramesh now, who's going to focus on quote unquote hot comorbidities and severe asthma. And then don't worry, after that, we'll take a little break. We know this is a lot of information. As we've said, please put any questions in the Q&A, not the chat, in the Q&A, because that's where we'll be looking for them. And feel free to add your questions as Ramesh is going, or anything from the last two speakers. So thanks so much. I'm going to turn it back over to you, Ramesh.
Okay, thanks very much, Hilary. I'll just get my presentation up. Great. So we've had a talk through how comorbidities are relevant in severe asthma and what impact they have overall. And in this talk, what I'm going to do is take the conversation deeper and try and look with you the most impactful or hot comorbidities in severe asthma. We'll go through a selection of those, and then we'll move on to look at the concept which is emerging of something called multimorbidity, how these comorbidities combine together. And we'll then go on to look at how multimorbidity particularly affects people with severe asthma. And following that, we'll look at how addressing the hot comorbidities and multimorbidity might help people live better with asthma. And at the end of it, if you are sitting there thinking, I've got comorbidities and multimorbidity, what can I do about it? I'll give you some tips. So here are a list of what, from our current understanding, we would recognize to be the hot comorbidities. You remember I talked about treatable traits at the end of my first talk. We could call these treatable super traits, things to go and target. So I'm going to focus on the ones in bold because they are the most common and very often the most impactful, and partly because we also have pressure on time today. So I'm going to start by focusing on sinonasal disease. And we've already heard about this from Ricky this morning. And it's an incredibly common comorbidity in people with severe asthma. Up to 50 to 80% of people with asthma experience sinonasal disease. And we know at a biological level that there is an immunological and messenger crosstalk between the upper and lower airways. So they affect each other. So we think of this as one airway, one disease. And when we think about sinonasal disease in severe asthma, we think about two particular kinds of problem. One is chronic rhinosinusitis, and the other is allergic rhinitis. So chronic rhinosinusitis is very much what Ricky was talking about there. Long-term inflammation of the sinuses and nasal passages present for more than 3 months. It may be associated with these things called nasal polyps, which are painless fleshy swellings growing in the lining of the nose and sinuses. And they give rise to very characteristic symptoms that Ricky so eloquently described, things like nasal blockage or congestion, facial pressure, muzziness, headache, loss of smell. And it can be really difficult to treat and really wearing for the patient. The kind of treatments that are available include nasal sinus rinses to clear the muck out of the nasal passages, steroid nasal sprays to reduce the inflammation. Sometimes antibiotics have a role to play. In severe cases, sometimes surgery might have a role to play. And biologic treatments are increasingly being explored and are available in some, but not all countries for this problem. Now, the other type of sinonasal disease that we see in severe asthma is allergic rhinitis, which is an allergic reaction of the upper airways and sometimes the eyes to inhaled allergen particles like house dust mite, pet danders, pollens. And it gives rise to typical symptoms of sneezing, nasal blockage, runny nose, drip down the back of the throat, and itchy, watery eyes. And of course, it can very often be seasonal in response to pollen exposures. And the treatment options include avoidance of allergic triggers, again, the use of steroid nasal sprays to reduce the inflammation that's driving this problem, and antihistamines to relieve associated irritation. And in some cases, allergen immunotherapy to induce what we call immune tolerance can be used, although we're quite wary of using that in severe asthma because of the risks of provoking asthma destabilization. But what about severe asthma and sinonasal disease? And I saw some questions in the chat being posted as well. And we have good evidence that in the presence of chronic rhinosinusitis with nasal polyps, asthma control, exacerbations or asthma attacks, and lung function are typically worse, and that the need for more advanced treatments like oral steroids are higher when severe asthma is accompanied by chronic rhinosinusitis. But we also know that treatment of sinonasal symptoms can improve asthma outcomes. And here's a really interesting fact. If you've got asthma and you have chronic rhinosinusitis with or without nasal polyps, and you get put on biologic treatment for your asthma biologic treatment response is often significantly better. So less in the way of asthma attacks, better asthma control, and greater improvement in lung function. So it can be a marker of good biologic response. Now, the second treatable supertrait that I want to highlight to you is gastroesophageal reflux disease. Now, this is a chronic condition where stomach acid or contents flow back into the esophagus or gullet, and it's seen in about 1/2 to 2/3 of patients with severe asthma. So again, very common. And this reflux leads to an irritation in the lining of the gullet, which can be associated with a variety of typical symptoms: heartburn, a sensation of regurgitation, things coming back up, chest pain, swallowing difficulty, chronic cough, a change in voice, nausea, and symptoms worsening when you lie down at night. And your doctor can usually make the diagnosis based on that clinical history and may simply go on and give you what we call an empirical trial of treatment with medication rather than do further investigations. But sometimes they may feel that those investigations are necessary, and they may include things like camera tests, what we call endoscopies, or more precise tests to assess the volume and the nature of the reflux, what we call pH monitoring and impedance. And sometimes they might want to do X-ray tests like a barium swallow. And in the context of severe asthma, we see that gastroesophageal reflux is 3 times more common than it is in mild asthma. And where it's present in a patient with asthma, it's associated with worse asthma symptoms, worse quality of life, more need for advanced and potentially toxic treatments like oral steroids, worse psychological comorbidity, more obesity and more sinonasal disease. So a host of negative associations. And we also see that in the context of asthma, gastroesophageal reflux predicts sustained poor asthma control and poorer responses to biologics. So it's not a good thing to have. But there are things you can do about gastroesophageal reflux. And these lifestyle changes are one element of the treatment pathway, and they're very important. They may seem trivial, but they will enhance your chances of responding to things like the medications. And the medications might be simple things like antacids, but they might also be medications to reduce acid production, like histamine receptor blockers and proton pump inhibitors or prokinetics that try and empty the stomach faster. And in more severe advanced cases, patients may end up needing surgery, which can be extremely successful. Now, the next treatable super trait that I'm going to focus on is a sensitive subject, and it's the subject of obesity. We're all quite sensitive about our weight, but I'm including it here because we find that it is incredibly relevant in severe asthma. 50% of patients in severe asthma clinics would be categorized as being obese. And let's stop and think about this. Over the last half century, we've seen a dramatic increase in the prevalence or occurrence of asthma for a variety of reasons. We've seen a tremendous increase in the prevalence or occurrence of obesity for a variety of reasons. And when the two coexist, what we see is increased inflammation in the body and in the airways, a reduced response to asthma medication, and a greater severity of asthma symptoms. And of course, when asthma is highly symptomatic, as it is in severe asthma, that reduces the ability to do physical exercise. But some of the asthma treatments, like oral steroids, also promote significant weight gain. So it's a really downward spiral in terms of combination. And we see that here in data from this study from Germany, which showed that in the presence of obesity, severe asthma was associated with worse asthma control, quality of life, and lung function. And we see that obesity also reduces your biologic responses in asthma. So you're less likely to have a response overall and much less likely to see remission, that thing I was talking about earlier. But there is hope with the biologics because they actually significantly impact obesity. They can promote steroid weaning and abolish the need for steroids in a group of patients, and they can promote significant weight loss. So there is hope there. And treating obesity needs to be part and parcel of our asthma management plan in the clinic, but it's really difficult. So the way to achieve this would be to set realistic goals and engage medical support. And part of that medical support will be for the asthma clinician to get the asthma medications right, to try and improve the state of asthma, to promote physical capabilities, and to avoid treatments like oral steroids that promote weight gain. Part of that might also be the consideration of the new weight loss medications, and we have had patients who've gone through bariatric surgery very successfully as well. But a lot of this is about behavior and lifestyle change, focused on nutrition and physical activity. It's not at all easy, but what we see is when patients can lose significant weight, their asthma gets significantly better. Now, the next treatable super trait that I'm going to focus on is another sensitive subject, and it's our mental health, psychological comorbidity. And we know that our mental health is commonly impacted by chronic illness and that worse mental health affects physical health outcomes. And over 40% of people living with severe asthma have either depression, anxiety, or both. And we know that some oral asthma medications, tablets like prednisolone, the steroids, can affect mood and promote low mood depression. And the symptoms of poor mental health that you see here in this picture that I've drawn for you are often ignored and therefore not really recognized or properly addressed. And we need to actually embrace this and look at these and recognize these for what they are. And in the context of severe asthma, we see that severe depression and anxiety are linked very clearly to worse asthma clinical status. And what this picture is showing us is that if both anxiety and depression coexist in the same person, the associated health burden and impacts are far greater than if they just have anxiety or depression. And again here, I've told you this with the other comorbidities. Psychological comorbidities predict poorer asthma biologic responses. So what I'm saying is that we now need to really embrace the concept that our mental health is really important to consider in our asthma management. And we need to consider this as part of the process of evaluating our patients and their long-term follow-up. And there are very many treatments that can be considered. A lot of these are coping strategies and talking therapies, but medications as well. And what I would do is make this statement really, that all severe asthma clinics moving forward should have access to multidisciplinary teams that can support the mental health needs of their patients. I think that is so important. Now, the fifth treatable super trait that I'm going to talk about today is something called breathing pattern disorder. And this is where we see altered breathing patterns that produce either intermittent or long-term breathing difficulty, plus a range of other symptoms that you see in the picture that I've drawn for you here. So those might be things like breathlessness that's out of proportion to what we would expect just from their asthma, sensations like frequent sighing or yawning, air hunger, hyperventilation, often what we call a mouth breathing pattern. You're actually designed to breathe through your nose, not through your mouth, but in dysfunctional breathing, you tend to abandon nose breathing. There can be associated features like anxiety or panic attack. And that clinical presentation can help us recognize the condition and diagnose it, but there are supportive diagnostic tools like the Nijmegen questionnaire and the breathing pattern assessment tool. And this is really common actually in severe asthma. This condition, breathing pattern disorder, occurs in around 50% of our patients. And as you see in this study from Southampton, there are significant associations of breathing pattern disorder with a range of other health problems, including gastroesophageal reflux, psychological comorbidity, and sleep apnea. And there are significant detrimental associations, bad effects of breathing pattern disorder in our patients. So worse asthma control, worse quality of life, more admissions, and actually ending up in places like the intensive care unit. But there is treatment, and the treatment typically is breathing control training delivered by physiotherapists. But I've put here a link to an online resource that's really good, which promotes self-help for this problem. So if you're interested, do take a look at that. And what we know is that these strategies to improve breathing control techniques can lead to improved asthma control and quality of life in our severe asthma patients, as shown in this study from Australia. And the final treatable super trait that I want to dwell on is sadly one that we cause in our clinical practice. And this is a treatment-related side effect, oral steroids. So oral steroids, treatments like prednisolone tablets, have been a core asthma treatment for years. And for many years, they were what we had for the most severe disease. They were all that we had. But they have a high side effect profile, which may cause or aggravate many comorbidities. And you see them here in the diagram that I've put together for you. So we might classify these under various headings. So under metabolic side effects, we may see high blood sugars, insulin resistance, weight gain, suppression of the adrenal glands, which are the glands in your body that produce your natural body steroid. And when they're faced with external steroid, they switch off. It may also disturb natural body processes like the menstrual cycle. Steroids can also cause side effects affecting the bones and muscles, so thinning of the bones, osteoporosis, leading to increased fracture risk, and sometimes muscle wasting. Eye problems can also occur, like cataracts and glaucoma. There can be gut or stomach issues like gastric irritation or peptic ulcers, and of course it can boost appetite. And it can affect your mental health and your mood, causing mood swings, anxiety, and depression. And oral steroids can affect both the skin and the immune system, so they can cause thinning of the skin and bruising. They can lead to what we call impaired or delayed wound healing, and they increase the risk of infection because they work by damping down the immune system. And I'm just going to touch on one aspect of oral steroid-related comorbidity in a bit more detail, which is adrenal insufficiency. And Hilary mentioned this in her introduction at the beginning. And this is where we see a suppression of the adrenal glands, which are your body's natural steroid producers, because the steroid has come in from outside. So they stop working. So you end up needing to take a low dose of steroid just to keep going because you can't produce your own. And patients with adrenal insufficiency due to steroids need to have a self-management plan to help cope with emergency situations. And I've just put the sort of points that they need to consider down here for you. So they need to take their steroids as prescribed, and they should never stop them suddenly. They need to have a backup plan if they become unwell for any other reason, because usually your body needs a high level of steroid on board in that situation. And they need to recognize the potential triggers for those situations, which are typically things like infections or other acute illnesses. And they need to avoid situations like dehydration or overexertion that can also promote that. And they need to be aware of the potential symptoms and signs of a problem, so tiredness, dizziness, nausea, low blood pressure. And they need to carry something like a steroid emergency card or medical alert bracelet. And really importantly, you need to, if you've got this problem, you need to tell all healthcare professionals that you come across that you've got it, because it could affect your treatment. But the bottom line is this statement I put here, that in the modern biologic era, we should simply not be starting patients on regular daily oral steroids anymore. So I'm hoping that this problem will become something for the history books in years to come. Now, you'll notice that when I've been talking about these comorbidities as treatable super traits, I'm often saying that they coexist with other conditions. And this leads us on to this evolving concept of something called multimorbidity, which is the coexistence of two or more long-term health conditions. And what research is telling us now is that this is the norm for people with severe asthma. They have multiple medical problems, but questions still exist because we're still at the early stages of understanding this in the context of severe asthma. So how does multimorbidity link with disease severity and adverse health outcomes in severe asthma, and which are the most important comorbidities towards that model of multimorbidity? And a very recent paper, hot off the press from our group in Southampton, gives us some really good insights into that. And this was the development of something called MIDAS, the Multimorbidity in Difficult Asthma Score. And for this, what we did was we did a statistical analysis using that assess score I mentioned in my first talk, which is the combination of factors that contribute to asthma severity. So we looked at a range of comorbidities to find out which ones were associated with significantly worse asthma severity as judged by the assess score. And we found that there were 7 conditions that were significantly associated with asthma severity. And these were gastroesophageal reflux, obesity, breathing pattern disorder, bronchiectasis, and this is non-steroidal exacerbated respiratory disease, so aspirin sensitivity. I haven't talked about this today. And sleep apnea, which I also haven't talked about, and rhinitis, sinonasal problems. And using these conditions, we then created a risk score that could help judge the degree of severity of asthma according to the comorbidities that a patient has. And we then tested this in a variety of other populations in Australia, America, and Singapore. And as this MIDAS score gets worse in all these populations, what we see is that patients show worse asthma control, greater signs of inflammation, both in the airways and generally in their bodies, worse psychological health, and worse quality of life. So what MIDAS is really showcasing is the co-occurrence of multimorbidity with the very worst outcomes in difficult to treat asthma. And it's strongly suggesting that we need a more holistic and multidisciplinary approach in severe asthma. And the hope is that MIDAS will provide a clinical score to wake clinicians up to this fact and help identify their patients most at risk from their multimorbidity. And to help them, we have developed an online calculator which they can access. And all they simply have to do is put yes or no into these boxes, and it'll calculate a MIDAS score, which will then identify the severity risk of the asthma and hopefully prompt them to address these problems. So something for the future. And a further glimpse into the future really is how can we target multimorbidity? And I'm just going to highlight one study for you here, which comes from Australia. And it's a really important study where they took a treatable traits approach in their severe asthma clinic. And they used a nurse specialist to coordinate this approach. And she assessed patients referred into the study for their treatable traits, identified what they were, and then issued treatment for those individual treatable traits. And what after 4 months was found is that compared to standard treatment, which was an asthma-focused management strategy by the doctor, this approach led to significant improvements both in quality of life and asthma control. So real food for thought for the future. So you might have been listening to my talks this morning and thinking, well, I've got these comorbidities and I think I've got multimorbidity. What should I do about it? So as I draw to a close, I'll give you a few words of advice, and I'd simply say talk to your general practitioner or your asthma specialist. They can start to address those with you. They can arrange appropriate tests. They can usually start appropriate treatment for many of these comorbidities, and they may sometimes refer you to other specialists, as you might be some of the people that I've highlighted in this picture here. So my final takeaway messages from this morning for you are that comorbidities are very common and highly impactful in severe asthma, but they are treatable traits that you can do something about. Most comorbidities exist in this model of what we call multimorbidity, and multimorbidity is highly impactful in patients with severe asthma. But again, it's likely that we can address that by considering the whole patient. And the final word I leave is for the healthcare professionals on the call. And to them, I would say, look for comorbidities in severe asthma and you'll find them and you should address them, and you will improve your patients' outcomes. So with that, I will just flash up my two advertisements, one for the research study and one for the allergy MSc at Southampton, and I will stop talking there.
Wonderful. Thank you so much, Ramesh. Lots of clapping and hearts and thumbs up. I think a lot of people really got a lot out of that. We're going to go to the Q&A now. We've had some questions being answered as we go, but Stefania and I will look at some of the questions in there and turn them over to you, Ramesh. And just for everyone to know, we might paraphrase some of the questions or combine them. So I'm going to jump right in. There have been some questions about biologics, Ramesh. So maybe we can get right into that. In particular, 2 points, if you can do that. Now, remember, everybody, we cannot give medical advice, but Ramesh can talk about biologics. So one person asked about biologics during pregnancy. So if you could talk about any papers or research they might look at to show the safety of that, that would be great. And another person asked, they said they're in the process of reducing biologics. They want to know if there's studies on what it looks like to reduce and stop biologics. So pregnancy, biologics in pregnancy, and reducing or stopping.
Sure, thanks very much for those questions. So biologics in pregnancy is a very interesting topic, and our clinical practice now, for instance, in the severe asthma service in Southampton, generally is to continue biologics for the vast majority of our patients in pregnancy. The evidence base for this comes from one study largely with the original biologic omalizumab or Xolair conducted in the US, which did not show significant side effects or problems during the pregnancy or with the newborn baby. There are also case series. There's one that we published from Southampton on patients who received the biologic benralizumab, and we didn't see any significant concerns there. But there are limited safety data on this. So what we always do is have an open and frank discussion with the patient about this and say we would be confident that it is okay to do, but we cannot exclude small risks, but we've never seen them. And almost always our patients elect to continue with their biologics because you're balancing otherwise the risks of coming off biologics during pregnancy and the risks of severe problems during pregnancy. And that is probably worse. Did you want to ask anything else about pregnancy and biologics, or
I think that's good. I think that's a great answer
okay.
And very helpful. And so the second one about
reducing
reduction or
biologics.
stopping. Mm-hmm.
Yeah. So there have been some studies looking at stopping biologics after a few years of treatment. Largely the ones I'm aware of are with omalizumab or Xolair again, because that's been our longest standing biologic. The studies that stopped omalizumab after 2 or 3 years certainly saw significant relapse or recurrence of asthma. There is at least one study that has looked at stopping after 5 or 6 years, and that showed that a proportion of patients then remained all right, but a significant proportion again still relapsed. And interestingly, in that study, when patients were then retried with omalizumab, they didn't always respond as well second time round. Now, that isn't so much of a problem now because we have a range of biologics to choose from. Our clinical practice, certainly in Southampton, is that we regard these as long-term treatments, and they're not something that at present we feel confident to give for a period of time and then stop.
Okay, great. Thank you. And it's very helpful to have you be citing these research, studies that help, show that there actually has been significant research on all of this, even if we don't always hear about it from our clinicians. I have a couple other questions, and Stefania, feel free to jump in anytime. And also, anyone listening, feel free to address questions to Ricky in the Q&A. He's here too to answer any questions. So, airway remodeling throughout life. I thought that was a great question. Are airways continually remodeled, even if maybe we're on the maximum amount of controller medications and biologics and things like that?
It's a really great question. I don't think we have a clear answer to this question. We know that remodeling begins really early. We used to think it was a consequence of long-standing disease, but there are studies where children in infancy have had samples taken from their lungs, which have shown evidence of remodeling at the age of 2 or 3 years. So it is established very early on. We have some evidence from research that we have done in Southampton in one of our studies where we have tracked people across the life course in the Isle of Wight from what's called the Isle of Wight birth cohort. And we looked at some patients who'd gone into natural asthma remission in their early 20s, and they still showed features of remodeling in their airways on what's called bronchial biopsy, despite seemingly losing their asthma. So there seemed to be a disconnect between the clinical state and the remodeling. There is some suggestion that biologic treatments may influence some aspects of remodeling, but I hadn't seen something clear in the literature to say that that's well established. And I think we need more research to look at that.
Okay. And there was a related question around biologic use in childhood to prevent lung damage and remodeling. So, do you have any thoughts to share about if there's an age limit at which biologics start to be introduced? How that decision-making process works with pediatric pulmonologists? Do you feel comfortable speaking to that?
I would have to say I'm not a pediatrician, although I do work closely with pediatricians through transition, and they do give biologic treatments to severe asthma patients in the pediatric age group. What we are not doing is using biologic as a preventive treatment in childhood to then try and alter the progression of the asthma and avoid severe disease. There are some studies that are looking at that, but we haven't got anything there to implement in clinical practice at the moment.
Okay. I'm going to ask one more, and then Stefania, I can turn it over to you. I like this question a lot because I know it's an area of immense passion for a lot of people in our patient advocacy group, which is fatigue. Fatigue is very common, and is it a treatable symptom?
I think it's a really complex symptom, and we, as asthma specialists, I think we're only beginning to wake up to the fact that fatigue is such a powerful impact on patients. And you talked about SHARP, and we'll hear about some of the SHARP research a bit later this morning. But one of the studies did ask patients what their most impactful symptoms were, and also physicians what they thought the most impactful symptoms were. And fatigue came out, I think, top for the patients, but barely registered for the physicians. I think it depends. Fatigue is multifactorial, and I think better asthma treatment, more effective asthma treatment will be one thing that will help address that, but also looking at the comorbidities may well help. And looking at the other factors, I think you have to look at the whole patient. So look at some of those things I was talking about earlier this morning and address those. And I think if you look at that whole picture, you're likely to start to improve matters.
To that point, I know one of the things you had touched on and is in the MIDAS survey is sleep apnea. Do you have any just really quick symptoms that people could look out? They might not know they have sleep apnea. That could be contributing to fatigue. Any top symptoms you'd recommend people look out for?
So one of the big symptoms will be excessive daytime tiredness, so falling asleep easily during the day. And one of the ways we look to diagnose that is by getting patients to complete what we call a sleepiness score. And that will tell us, if they are excessively falling asleep during the day or tired, but also they may report waking unrefreshed from sleep first thing in the morning. They may have disturbed sleep with frequent awakenings, because that's a hallmark of sleep apnea and why they're so tired during the day. Sometimes it may not be the patient, though. It may be their partner, their husband, their wife, whatever, who complains that, yeah, she really snores really loudly, and she stops breathing sometimes in her sleep, or he.
Excellent. Okay, thank you. Stefania?
Yeah, thank you very much, Ramesh. It was really interesting and very comprehensive. It's impressive how much you summarize everything in such a short time. I see here also, to me, another important point that should be discussed, the association between psychological comorbidities that predict a worse response to biologics. And they're asking if there are any specific studies to look into, since it's a very important point that you raised also in your presentation.
Yeah, and I flagged up a couple of the studies there. One was what we call the meta-analysis, which is the overview study that Liam Heaney's group did, and that identified these as independent predictors of failure to achieve good response and remission. And the other study I flagged up was one of ours from Southampton, which showed that psychological comorbidities occur in almost half of our patients if we look for them. But they impair biologic responses. And what we now need to embark on, I think, is a much more what we call holistic approach in our patients. And if we want better biologic responses, I think we need to look at the whole person, not just the asthma part of the person, and treat the other aspects of their health. And if we do that, we're likely to start to see far more positive responses to biologics, and I suspect more people achieving remission with biologics.
Thank you very much. Yeah, fully agree. And I think that it's all connected also in terms of a sort of step up and evolution of our management in the disease. I see also many questions that are also related to that. So what's the connection with the primary care? How can we increase awareness to our GPs, so for example, to make sure that they also look at comorbidities and treat them maybe before arriving to the specialist.
And that's a really important point. And it's about increasing awareness, I think. And at Southampton, we're working with our primary care colleagues and researchers. And actually, it's really interesting. It's been thought that comorbidities and multimorbidity are the preserve of patients with more severe asthma. And actually, we've looked at patients with mild asthma. And people with mild asthma still have loads of comorbidities. And they have models of multimorbidity, which are sometimes different to those with more severe disease, but they need to be addressed. And it's whether addressing those at an early stage then improves the health of patients so that actually they don't show a deterioration in their health and end up as a severe asthma patient.
And I think, and Ricky, feel free to jump in on this with me. From the patient point of view, I think that question and Ramesh's answer is probably the most important point that we're hoping you take out of this morning, which is, unfortunately, as many of you have noted in the chat and the Q&A, sometimes as a patient, I can say, I feel like I'm a car and I see one doctor for my headlights and I see one doctor for my steering wheel and I see another doctor for, the bumper, and none of them talk. And it seems crazy because it's one car. And I think an overall message from today, there's 73 countries on here. Every country has different ways of, you have to get a permission from your GP to see this specialist, or sometimes you can contact specialists yourself. But I think our point is, you are your own best advocate. And hopefully from today, if you saw anything in Ramesh's slides and you said, oh, interesting, I do have that symptom, or maybe I have acid reflux, to go to your GP and say, I really want to see an ENT, or I think I'm having some real anxiety and depression from struggling with a really severe disease and maybe adrenal insufficiency. And so realizing that unfortunately your pulmonologist and GP might not ask you about those things, and you have to come to them with these concerns about comorbidities. So
could I add to that, perhaps?
Yeah, please.
I've found, obviously, having comorbidities is an issue as a patient. But within the UK, and I can't speak for other countries, the general practitioners that we tend to see most, because we don't see specialists most, are kind of rather restricted from time-wise how much time they can spend with you. And therefore, there's a limit to how many comorbidities that they can discuss. And this is where, being a patient, our own advocacy comes in. I personally contact my surgery and say, look, I've got a number of conditions that I need to discuss to the doctor at the same time. Could I have a double appointment? And I will make a longer appointment so that the doctor does have the chance to answer various related conditions that interact with my asthma. So you can't really expect the doctor necessarily to want to discuss comorbidities because of their time constraints. You might have to kind of ask for it.
Great point.
Wonderful. Very, 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 very good point. Very important. And another thing I think we can encourage everybody to do is to look for severe asthma specialty centers in their countries. Sometimes, if it's possible, it's worth traveling to those. We have a list on the SHARP website of about 30 or 40 in Europe. I can't speak to all the countries outside of Europe because that is our focus. But for example, I live in rural France. I could not find a good specialist here. Through the SHARP network, I found an excellent severe asthma specialist in southern France. It's far, but the first time I went, like Ramesh said, they had a full multidisciplinary team. They had nutritionists, they had a psychologist on staff. It was incredible. And those clinics do exist. Your GP and your pulmonologist might just not know of them. So we can put in the chat a link to the severe asthma centers in Europe from the SHARP website for sure. Sorry. Okay, Stefania, go ahead. Another question.
Oh, I think that's a great idea, Hilary. I just want to address, I think, another important topic that Ramesh touched upon about remission. We have received some questions. Is remission in asthma also affecting and the possibility to achieve a remission for comorbidities? So, for example.
Yeah, I mean, I have to say we're very much in the early stages of understanding what is remission in severe asthma. There's a lot of discussion amongst the experts as to what qualifies as remission and how it's actually achieved. And we haven't moved that on to look at the comorbidities in any great detail, but certainly you can see in our patients who have conditions that can be treated by the biologics, for instance, such as sinonasal disease, that asthma biologics can lead to significant, profound improvements in some, not all patients. Depends on their individual nature of problem. But I also have patients with skin problems, like eczema, who are treated with particular asthma biologics that can treat both the asthma and the skin, where they have had profound improvements in both conditions, and other people who have other skin conditions like urticaria, where a single drug treats both the asthma and the urticaria. So I think this is where we need to focus on. And increasingly, we in our clinical practice, when we're selecting biologics for patients, we often struggle if they qualify for several different types, which one to choose. And we're increasingly looking at the bigger picture. What other health conditions they have? Could they benefit from this drug because it could treat their asthma, their rhinitis, and their eczema, for instance?
Stefania, I want to let you keep going. I want to jump in because someone asked if there's resources for adrenal insufficiency to give their clinicians, because a lot of the time clinicians don't know about that. This is my particular area of passion, so I'm going to drop 2 links into the chat. They're both for foundations. We only are working with, organizations that do extensive research on this. So the National Adrenal Diseases Foundation and the Addison's Disease Self-Help Group in the United Kingdom both have terrific resources that you can print out and bring to your clinicians. They have medical ID bracelets for your to wear, to have in your car, in your bracelet. So I'm putting those in the chat for the questions about adrenal insufficiency.
Perfect. Great. Thanks, Hilary.
On the subject of adrenal insufficiency, the NHS in the UK do actually have a patient kind of warning card about adrenal insufficiency in case you are on, say, daily prednisolone or something. And that card is to be able to show ambulance crew or hospital, if you go in an emergency, to warn them that you may have adrenal insufficiency. And it's a handy thing to carry, but not all doctors or pharmacies might offer it to you. So sometimes you might have to say to them, oh, I'm aware that there is this card. Could I perhaps have one? So again, it's a case of a patient asking for something.
Okay, we have time for maybe one last question very briefly. Stefania, did you see anything else in the Q&A that jumped out at you?
Yes, I think, it's more like it's a quite interesting question related to the biologics itself. So patients that are on biologics see that sometimes temperature might have an impact on the efficacy. That's actually what they refer. So if you have heard anything on how the right temperature of the medication is important and what to advise to do also for doctors.
Yeah, it's a really interesting question. I mean, I haven't come across many patients coming up and back to clinic and saying that the temperature of the medication influences it. I think we had, because very often you store the biologics in the fridge and they're administered at home. I've had one or two patients saying that if they take it straight out of the fridge and use it, then they don't find that it's as good as if they allow it to acclimatize to room temperature. But I have no hard and fast guidance on that I could speak to. I don't know, Stefania, if you actually have any.
That also why raised a bit my attention. So yeah, it's true that in for my personal experience, of course, so it's very limited. We tend to wait a bit before really giving the medication, and we put it out of the fridge for quite a while. But that does affect the efficacy of the biologics. Indeed, it was also interesting to me to see that there are these impressions, let's say.
Wonderful. Well, thank you so much again. We're at the exact time to take our 10-minute break. We're going to take a 10-minute break. We'll be back at 11:30. Thank you so much again, Ramesh and Ricky, and we'll see you in 10 minutes.
Okay.
Dominique, just checking that you're there.
Yes, I'm here. I'll
Perfect.
switch on my camera as well.
Great. We might
Thanks.
start with you.
Okay,
Okay.
because we're still missing Anna and
Yes.
Florence.
Yes.
Okay.
Well, no, Florence is Florence is
No,
good.
no, I know about Florence, but sort of.
Yeah.
Okay.
Okay. So welcome back, everyone. We're just going to take another minute to get settled, and so if you're grabbing a coffee or stretching or tea, keep doing that, and we'll be ready to go in 1 or 2 minutes. This is so great for everybody in attendance. We love seeing your reactions and comments in the chat. I just opened the chat and saw that Rosalind says, I'm learning so much today, and we're only an hour in, so that's wonderful. We're so glad to hear that.
Yeah, definitely.
I think we're going to go ahead and get started with another patient, Dominique. I just want to confirm, Claire, we're good to go for the slides, correct? For Dominique's slides?
Yes, we
And the
are. Yes.
polls.
And the polls, we are. Yeah.
Okay,
Good.
wonderful. So am I okay to begin? Okay, wonderful. So I'm going to introduce Dominique. She is one of the most passionate members of our PAG, our patient advocacy group, I should say. A patient advisory group. She works closely with many clinicians on a lot of research. She's just a real fantastic voice in the severe asthma space. So thank you so much for joining us, Dominique. She has a lot of experience with dysfunctional breathing and is going to share that today. And I'm going to turn it over to her now. Thanks, Dominique.
Thank you, Hilary. Can we have the first poll, please? And you can answer the poll on the little poll thing that popped up. Well, this is nice. We have a lot of people with severe asthma, family members or carers. Really good. We have healthcare professionals and patient organizations. And for me, it's surprising how many people have heard of dysfunctional breathing, which makes me very, very happy. Stay on the first slide, please. Yeah. For a very long time, each year, I had many months that I was breathless. I could do very little, would spend most of the day in a chair or lying down trying to breathe. Each time I went to my primary care physician in tears because I couldn't breathe. None of my treating clinicians had seen this or done something with it while I had told them. One day, my primary care physician had enough and said, they need to see you like this at the hospital and send me to the emergency department. I could barely get myself there, tears rolling down my cheeks, having a hard time breathing. I got admitted to the A&E, still having a hard time breathing, reading my book, waiting for the different tests they wanted to perform. It turned out the CO2 in my blood was too low, changing the chemical balance, the acid-base balance, which has a big effect on your whole body. Next slide, please. They sent me home with an anti-anxiety medication and nothing else, as they felt this is hyperventilation. In their mind, hyperventilation equals anxiety. The doctor clearly did not look at me. Someone with an anxiety attack is not sitting there reading a book. It took me a while to put the puzzle together. If it is not hyperventilation and anxiety, what is it? I started looking online for research on disturbed CO2 levels. Almost all the articles were on hyperventilation and anxiety. Finally, I found a mention of dysfunctional breathing, disturbed CO2 levels in the blood, problems breathing, but no or little anxiety. I even found that there was a treatment based on physiotherapy and speech therapy that could help. However, nobody in Amsterdam knew much about it. I found a lung physiotherapist who was willing to work with me, and she knew a speech therapist. We started on our journey. They were amazed on how fast my breathing became dysfunctional and helped me to become more aware of my breathing, to breathe with my diaphragm, as we already heard from Ramesh as well, and retrain the breathing center in my brain to get used to breathing this way again. Next slide, please. With dysfunctional breathing, the process of CO2 and oxygen exchange in the lungs is disturbed and can lead to too little or too much CO2 in your blood. There are a lot of factors that can cause a change in pattern in your breathing. Mouth breathing, but it can be difficult to avoid if your nose is blocked. Environmental factors in the air we breathe, like humidity, cold, heat, air pollution, hormones, fever and infections, caffeine and drugs, laughter, talking, stress, anxiety, fatigue, and of course your severe asthma. What I also found out, and that always having 100% oxygen saturation in my blood instead of the normal 96 to 98% is also a marker for dysfunctional breathing. Next slide, please. It took quite a while to retrain my breathing, to become aware of my breathing and learn how to relax my breathing pattern. Do not worry too much about your breathing. That does not help. Observe what is happening. Try to breathe through your nose to your belly, expanding your diaphragm. It might help to put your hand on your belly near your belly button and breathe out through your nose or pursed lips, relaxing your diaphragm. Sit down or lie down, either flat on your back or reclining. Breathe in, expanding your diaphragm. You can support this with a slight movement forward in your lower back. And breathe out, relaxing your diaphragm, moving your lower back again. Relax. Try not to stress about it. Allow your emotions. Distract yourself by doing something you enjoy that's not too strenuous, like listening to music or reading. Share your experiences with fellow patients. What I still find very strange in severe and in all asthma, that there is so little attention given to how we breathe. Next slide, please. And we can put up the next poll. This is also an interesting result to look at. And I want to finish my presentation with a small relaxing exercise. And it doesn't matter what your current position is, whether you're sitting down or lying down or want to stand up. What we do is you'll stretch out your arms, bend the big back backwards while you breathe in to relieve the tension in your chest and back, and then breathe out. You can yawn or sigh. This helps as well. So this is a really, really easy one that can help balance your breathing when you think, something is going on. Thank you for your attention.
Great. Thank you, Dominique. That was wonderful. And I think we had some good responses in the chat, some questions around whether there's respiratory therapy videos. So we'll come back to that in the longer Q&A. We'll do a little research and find out that question about the videos. But if anyone would like to ask some quick questions, we have a few minutes for you to ask some questions of Dominique about her own experience as a patient, breathing exercises, anything like that. Feel free to put them in the Q&A.
I see, Hilary, a question here.
Great.
How do you feel, Dominic, about the term dysfunctional breathing? I think it's actually quite interesting to see because it's impactful. I can imagine.
Yeah, what my biggest problem was is sort of they immediately put it into anxiety or depression, sort of the mental terms. And I don't say you can't have anxiety or depression, but your breathing itself has an impact on your emotions, as you could see in my last slide. So if and I feel that it is a good term, dysfunctional, because it doesn't limit what could cause it or what you could do about it. It just isn't as it is supposed to be.
Yeah.
And someone had asked about if there's any good to build on that. Someone had asked if there's any good resources online. There's so many, the Asthma and Allergy Foundation, but I put in the chat the Asthma and Lung Foundation because they're wonderful. We work with them a lot. They have great breathing exercises on the website. So I just dropped that into the chat.
Yeah, and I haven't, when I started out, there was nothing. There was one article or two articles from physiotherapists who said, we can do this, but there wasn't really a description about it. And I think the Breathe Freely link that Ramesh also shared might also be a good program. And what I sort of, my training was, I was doing exercises like pushing away weights, and then my physical therapist really, really looked at me, and she immediately noticed when my breathing was becoming dysfunctional. It became too high. And then we went into a relaxation room where I sat reclining, and she taught me sort of now try and relax and try and get your breathing down to your diaphragm, put your hand on your belly. And I found that this little movement in your lower back is really, really helpful because it also relaxes your the long muscles in your back that support your whole body. So it also relaxes all your secondary breathing muscles.
Mm-hmm.
It's a
Wonderful.
mini trick that works really, really well.
Yes, and someone had asked in the chat why we don't see why we're not regularly referred to physiotherapy, and I think or someone asked that in the Q&A rather. I think that's an excellent question. It goes back to Ramesh's presentation on all these comorbidities and how so often we don't get referred to the things unless we ask for them. Our GP and pulmonologists might not even know to do that. I mean, I've had asthma since I was 8, and I don't think I was referred to a respiratory therapist till I was in my 30s. I don't think so. That's very normal and unfortunately, but it is one of those things you can flag and push for. And at the European Respiratory Society Congress last month, there was some really fantastic presentations and research on very specifically long distance basically teletherapy and for pulmonary respiratory support. And I thought that was really exciting to see.
Yeah.
Ramesh, are you able to pipe in?
Yeah, if I may, Hilary, and by example, I did get referred to physical therapy quite often, but not breathing physical therapy. So more, oh, you need to exercise more, you need to keep your muscles strong, but not really emphasizing the breathing part. And what I found in looking for my physical therapist, you have specialized lung physiotherapists, but breathing pattern, well, it might have improved in the last years. That's not such an area of impact, and they usually can only measure your oxygen levels, but not your CO2 levels.
Interesting. Okay, so Ramesh, I just want to ask this question to you quickly, and then we'll transition to Dr. Freeman. The question is, if a patient is interested in physiotherapy, but their doctors have not recommended it, their pulmonologists, their GPs, is there anything that you would suggest to help them pursue that kind of treatment?
Well, I did signpost there are online resources now, which are really good, and they have been shown to be very effective. So that could get somebody started on the journey. But it would be a conversation. Most severe asthma centers and specialists should have some sort of access now to a physiotherapist to support the needs of the severe asthma patients in terms of breathing control. And certainly that's an established part of severe asthma centers in the UK. But the online resources would be a good starting point.
Okay, great. And if you want to drop anything into the chat, Ramesh, as a reminder from your slides, that would be wonderful. There's a lot of questions about this. So I am delighted to introduce our next speaker, Dr. Anna Freeman. Oh, sorry. Thank you, Dominique. Thank you very much, Dominique. Wonderful.
You're welcome.
So Anna, Dr. Anna Freeman is an associate professor and respiratory consultant in Southampton. Her research and clinical interests are in severe asthma multimorbidity and how the body responds to physical activity. So she's going to walk us through right now some of the research that's happening on multimorbidity. And I think for all the clinicians in the group, it'll be really interesting to see this data and information, and for all the patients to know that even though we don't hear about it, there actually is tons of research going on our condition and on comorbidities. So with that, I'll turn it over to you, Anna. Thank you.
Thank you very much for the introduction. Can I just check that everybody can see my slides and they are now in presenter mode?
Good.
Fantastic. So following on from Professor Ramesh's talk about multimorbidity and the impact that it has in severe asthma, I'm going to speak more specifically about some research that we've been working with the SHARP collaboration. So SHARP is a European Respiratory Society sponsored and funded collaboration that crosses a significant number of countries in Europe and takes patient data from their national registries and puts them into what's called a federated analysis platform, just a big database essentially, so that we can understand severe asthma across Europe and look at patterns. One of the work streams within this, led by Professor Ramesh, which I'm involved in, is the multimorbidity work stream. And we've had some really, really interesting work from that, and that's what I'm going to talk about today. So back in, I think it was probably 2022, that we first started thinking about this work stream and talking to patient representatives and realizing that actually this was a key area of importance to patients. We sort of worked up an aims and objectives plan for this work stream, and set out a few projects that we wanted to complete. So that's the first slide that I will go through, and what we intended to achieve. And then following on from that, we've got these research projects looking at the comorbidity prevalence across Europe, so the other long-term conditions that patients suffer from, and then moving on to look at the patterns of these comorbidities and how they group together to create very different patterns of disease. And then we'll look at some work that we've done on the physician survey, which was looking at doctors' perspectives on multimorbidity, and how they differed between those doctors who were severe asthma consultants and those who were more general respiratory physicians. And then I'll just sum up what we've been through. So a lot to cover in a relatively short time. So when we set out to undertake this project in SHARP, we wanted to look at which data we were capturing as part of our national registry data. And in that big SHARP database, we wanted to look then at the frequency, how often these comorbidities occurred across different countries. I think Ramesh has spoken a little bit about the patient survey and how we want to get patients' experiences and views on multimorbidity, and look at how they match and don't match with physician and other healthcare provider views on multimorbidity. And we then went on to look at the sort of patterns of multimorbidity within those separate comorbidities. So firstly, I'm going to talk a little bit about comorbidities across Europe. So these are the individual sort of patterns of additional long-term medical conditions that people with severe asthma also have. So we looked at the European National Severe Asthma Registries. So that's 22 European countries and over 13,000 patients. And we wanted to establish what comorbidities people had, and also which data we were capturing, because you can only look at the list of comorbidities that people are making a note of in their national registries. So we identified 48 comorbidities that were listed across those 22 countries and grouped them into 5 different groups. Now, I appreciate this is a very busy slide, so I will talk you through it a little bit. So we have the sort of asthma inflammation related comorbidities, the T2 related comorbidities, and they were things like nasal polyps, dermatitis, so things like eczema, and allergic reactions. Then we have pulmonary comorbidities, so things that were linked to the lung. And it's very common that you get a little bit of bronchiectasis or scarring on the lungs from lots of infections, and then other sort of airways diseases alongside that. Extrapulmonary is anything outside of the lungs. And then we've got the psychophysiological group. And again, we've seen both in clinical practice and in our research that it's really common when you're suffering from a chronic disease to have some anxiety around this, and to have some low mood associated with that as a very normal reaction to struggling with day-to-day symptoms. And then finally, the last group that we had was steroid related. So particularly prior to the sort of targeted biologic treatments, steroids were the mainstay of treatment that we had available, and they still play a really important role in the management of asthma, but they are drugs that have lots of side effects, and we can see that in patients who have severe asthma and need those courses of frequent steroids, that actually they're quite common comorbidities to be reported. So again, another busy slide, but what we can see is that not all comorbidities were captured equally. So people were very good at capturing data on nasal polyps, they weren't so good at capturing data on allergic reactions. So in that first top left box, you can see that only 9% of the countries collected data on that. And again, we were good generally at capturing data on obstructive sleep apnea and on COPD, but less good at capturing data on some of the less common lung-related comorbidities. And again, it varied across the extrapulmonary ones. We are really good at capturing obesity data and acid reflux data, but less good at capturing data on gastric ulcers, peptic ulcers. And they're not uncommon because they can be a side effect of steroid treatment. Again, we were good at capturing some of the psychophysiological comorbidities, but less good at capturing others. And again, with the steroid related. So you can see that even though all of the national registries do capture some data, they don't capture it across the board, and it's very variable. So if we're not collecting that information, then it's hard to be able to understand exactly what's going on. So to summarise this project, we can see that comorbidities are really prevalent across European severe asthma populations. But despite this, and despite doctors sort of becoming increasingly aware of this, we're not capturing all of them, and particularly the steroid-related conditions. And so we need to sort of standardise our data collection a little bit more so that we do capture all of those comorbidities across those 5 groups. We then went on to look a little bit more specifically at the patterns of comorbidity. So phenotype essentially is describing a pattern of disease. And we wanted to look at severe asthma and whether the patterns of multimorbidity had impact on what sort of symptoms and exacerbations and severe asthma people suffered from. So again, we looked at the patient data from the SHARP database, and then we grouped patients into 4 geographical regions. Firstly, to try and understand if the comorbidities differed across Europe. You know, life in the south of Europe can be very different to life in the north of Europe, and geographical influences and environmental influences, things like typical diets, may have impacted on comorbidities. And so we wanted to look to see if that differed across those regions. We then wanted to look at grouping patients by their combination of comorbidities. So not really looking at the asthma side of things, but looking at the other long-term conditions that patients had and looking at the impact on asthma that we saw. And we called those groups multimorbidity phenotypes, and then looked at their pattern of asthma alongside that. So again, what we could see is that comorbidities were really high. So we had 11 countries participating in this study. The overall study population was 2,690. The majority was female, about 60%, and that's reflective of severe asthma populations. Disease severity was high, so 70% had 2 or more exacerbations needing steroids in the past 12 months. Biologic treatment levels were high at 79%, and 30% of these patients had daily regular steroids. There was quite a lot of variation across those countries, but even with that, we saw that patients had at least one comorbidity in about 96% of in 96% of patients, and the median number, so the average number of comorbidities was 3. So it's a high burden. You can see that a lot of the patients came from the Netherlands just because they had the most data available to analyse. but we've still got a good breadth of countries. So here again, a busy slide and hard to see, but the bubbles represent the frequency, so how commonly these comorbidities occur across the 11 different countries. And you can see from the size of the bubbles that it's really variable on a country by country basis. So for example, looking at reflux disease, in some countries it's as high as 55%, in other countries it's as low as 14%. And you see that across the different comorbidities. So there is some difference across countries. The 10 commonest comorbidities all had a prevalence of more than 5%. So 5% of patients had these comorbidities across the different countries. And if you look across north, east, south, and west, you can see that the frequencies of some of these comorbidities are quite high, but did differ between the different geographical regions. So we are seeing different patterns already when we look at patients just across where they live. So this is just to sort of show how we have separated up the geographical regions. So in the north, we've got 4 countries. In the east, we've got 3 countries. In the south, we've got 4 countries. The west is represented only by data from the Netherlands, but it's still a good number of patients. We then looked at patterns of comorbidities and saw that in the yellow line, you've got the nasal polyps, the sinusitis, so upper airway symptoms, rhinitis, the sort of nasally symptoms clustered together, and that we called cluster 3. In cluster 2, we have got eczema and rhinitis. And in cluster 3, we've got in cluster 1, we've got the osteoporosis and the steroid-induced weight gain. We did have 4 comorbidities that didn't fit consistently with one group across all of the European regions, and those were bronchiectasis, obesity, reflux, and psychological comorbidities. So what we can see is that despite lots of differences between comorbidities in different countries, the groups of comorbidities seem to group together quite consistently. And this is just another way of sort of demonstrating those patterns where people had different collections of comorbidities. So we then grouped patients based on which comorbidities that they had. Some patients had none of the stable comorbidities, but that didn't mean that they were comorbidity free. They just had some of those comorbidities that didn't fit with a particular group. Some patients had comorbidities in all of the 3 clusters, and so they were sort of high multimorbidity, and some patients just had 1 or 2 of those stable groups. We then looked at asthma patterns when patients were grouped by which comorbidities they had, and saw really significant differences. So those patients who had comorbidities but didn't have the stable clusters 1, 2, and 3 tended to have worse control. They had later onset of disease and relatively low T2 inflammatory markers. At the other end of the spectrum, those patients who had comorbidities in each of the 3 stable groups had the greatest comorbidity burden, and their pattern of asthma was that they were more likely to be female. They had higher blood eosinophils, so those asthma inflammatory markers, and high levels of steroids. Across the other groups, you could see different patterns as well. So those who had the clusters 1 and 2, so the nasal symptoms and the asthma markers, tended to have earlier asthma disease, but lower airways inflammation, and maybe that was reflective of longer disease duration. So it's really interesting to see the variation across those groups in asthma symptoms when patients are grouped just by their comorbidity burden. And again, this is another way to sort of describe those groups. So those in group 0 without those stable disease patterns, as I said, had later asthma onset, more likely to smoke, had lower lung function, but lower steroid and biologic treatments. Those in group cluster 1, who carried only the cluster 1 comorbidities, had more steroid associated multimorbidity, lots of steroids in the past, higher levels of obesity, poor asthma control. Those in group 2 were the more allergic sort of pattern. And again, you can see that they had a slightly different pattern of disease. They had earlier onset asthma, but actually they seem to be better controlled. And perhaps this is a more benign disease status. Then you had the nasally cluster, that cluster with polyps and rhinitis. And again, they had a different pattern. They had later onset of asthma, but higher asthma inflammatory markers, and seemed to perhaps respond better to disease. And then you saw the patterns of those with the grouped comorbidities on the right hand side. And again, they had different sort of asthma trajectories. So with all of that information, we can see that the comorbidity story is really important, not only to managing patients as a whole, but also to managing asthma, because it has an impact on asthma symptoms and patterns of disease. So we looked at the physician survey. The study was conducted within SHARP again. So all of those 22 countries were invited to participate through their national leads. And we wanted to get an idea about access to the multidisciplinary team, and what doctors thought on multimorbidity, and compare that, as I said, between severe asthma physicians, so people whose subspecialty is severe asthma, and those who just do a bit of severe asthma alongside their general respiratory work. So, international study, we had 495 responses from 25 European countries, and the survey was sent, as I say, through the SHARP network, which is a great sort of resource. And that's a screenshot of the questionnaire, just sort of highlighting some of the questions that we were interested in. The survey explored access to resources, so whether doctors were able to get the support they needed to manage comorbidities, whether they felt confident as respiratory physicians to manage these other comorbidities, and what the challenges were in that management. So the split between the severe asthma specialists and the general respiratory physicians was relatively equal, which is great because it gave us a good idea. The largest groups came from Romania, Croatia, Italy, Belgium, and Switzerland. So again, a really busy slide, but just showing you the numbers of respondents from each country. And again, we've got a really good geographical spread across Europe. The differences between the two groups. So severe asthma specialists more often performed a good and thorough evaluation of comorbidities, and more frequently recognised multimorbidity as having a major impact in severe asthma outcomes. And it's one of those things that maybe because as severe asthma physicians, they have better access to the multidisciplinary team, so specialist nurses, specialist physiotherapists, to do things like breathing pattern retraining and to support sputum clearance and all of that sort of thing, and other allied health professionals. Even across severe asthma specialists, there were barriers to investigating and finding out more about multimorbidity, and they're things that you probably could guess at, but some of it is lack of time. I think only a few people lacked enthusiasm, and I think as we demonstrate more and more through all of our work how important multimorbidity is, I think that lack of enthusiasm will reduce even further. Lack of awareness, again, I think that will be addressed by the work that we're doing in SHARP and across other sort of multimorbidity work streams. Lack of clinical expertise. People were relatively confident, but there still are people who are uncertain about how to manage multimorbidity. And big one was lack of funding to support those multidisciplinary team support. In primary care in severe asthma, we looked at whether there was enough understanding about multimorbidity in the primary care community. And this was the views of the respiratory consultants. And I think that they felt that within primary care, there was some uncertainty around how to manage multimorbidity, and whether there were enough local initiatives to support that understanding. So I think that's an area that we can work on and communicate better with our colleagues in primary care. We have got here just the number and percentage of severe asthma patients seen by the professional roles. So you can see here that the severe asthma patients the severe asthma physicians do see more patients than the general respiratory physicians, and that can impact on so the confidence in managing multimorbidity in asthma. Again, we can see the comorbidity data collection compared between those general respiratory physicians and the severe asthma specialists. And you can see that comorbidity data is much more likely to be collected on the left-hand side at that first consultation and on the right-hand side at that follow-up consultation as well. So we can see that that severe asthma specialists, maybe because they see more patients or because they have greater awareness, are better at collecting that comorbidity data. And again, we've got the extent to which multimorbidity is taken into severe asthma management. Again, these severe asthma specialists are better at putting emphasis on the importance of multimorbidity. And I think, as I say, as awareness around multimorbidity increases, that will move down into or move across into general respiratory physicians and primary care as well. So the differences between views of severe asthma physicians and general respiratory physicians likely reflect a combination of things. So some of it training, subspecialty training, some of it just what people are seeing in their general clinical practice. If you're seeing lots of severe asthma patients, which we know have significant multimorbidity, then you will have better experience, and also structural support, so access to that MDT. Common things between the two groups, so insufficient training in multimorbidity was reported by both groups, and access to that multidisciplinary team, although better in severe asthma settings, is still an issue. So yes, it's important to be aware of it, but we also need to make changes in systems and healthcare settings to be able to access treatment for this multimorbidity, taking us to that more personalised medical treatment. So the recommendations from this physician survey are that respiratory societies and healthcare systems should include education on multimorbidity in both specialist and general training, bringing together clinical protocols such as through SHARP would help harmonise, so make more similar that data collection across Europe, and promotion of that multidisciplinary team with lots of different specialists to target those conditions would be really helpful in improving care. As multimorbidity gains recognition in severe asthma, we should start changing guidelines to include that and to address it explicitly. So the work that I presented today was done by the multimorbidity core group with support from the wider team, and I've got the team members there. I'd like to specifically highlight Sasha and Darche's role in this, and their hard work in taking through those different projects. And thank you very much.
Thanks so much, Anna. That was great, really interesting research. A little intensive, I know, probably for some of the people in the audience, myself included. It's a lot of data and information, but we have some time for a Q&A with Anna right now. So if you'd like to go ahead, remember, put your questions in the Q&A.
I see one question that actually I think it's nice for everyone to clarify a bit. Indeed, you presented amazing results, a lot of information. There was a specific graph where there was the MMP 1, 2, 3, 4. If you can briefly, shortly explain that a bit to the audience, because of course there was the doubt if it was related also to increase of severity of the disease or the comorbidities or not. So that would be helpful. Thanks, Anna.
Sure. So let me bring up that slide again, if I may, and I can talk people through the different groups. So the different patterns of comorbidities are not necessarily related to worse severity, but we do see different patterns of asthma. So not necessarily severe across all of the groups, but just different patterns of asthma. And it makes one think about perhaps targeting them in slightly different ways. So that first group of patients who didn't have any of the particular comorbidities that went into those quite fixed groups had slightly later asthma onset. They were perhaps more likely to smoke overall, with worse lung function that could be related to that smoking history, and they did have worse asthma control. In the second group were patients who had lots of steroid associated multimorbidity, and they also had higher levels of things that didn't cluster particularly with any group, and they had high steroid use, which you would assume if they had lots of steroid associated multimorbidity, they had lots of exacerbations, which is probably why they were getting lots of steroids. The allergy pattern is what we've seen from work looking at different patterns of asthma before. They tended to have earlier onset disease, but actually seem to have a less severe pattern of disease. Those with the high asthma markers, so the high eosinophil count, high T2 traits, seemed again to perhaps respond better to treatments. And then those in the group that carried all of the comorbidities did seem to have a higher burden of comorbidity, but also worse asthma control and higher steroid use. And the sort of suggestion there is that we need to target treatable traits. So we need to treat the asthma. We also need to treat the comorbidities alongside that, and that targeted approach should give people a better chance of a good outcome and improvement in their asthma control. But I suppose coming back to what we've talked about before, if you don't ask about the comorbidities, then you don't know what you need to treat.
Exactly. And that's also, I think it's very important to connect into that. Of course, you're using sharp data that are based on a real world registry, but it's interesting to see that not the full spectrum of comorbidities that we have available are really captured. And what do you think is the reason for that? It's because we don't have standardized objective measurements, for example, or...
So I think it's a combination of things, really. I think perhaps it is that lack of standardized protocol. It's not knowing what to ask about. And that's where our patient survey will come in, because so far, all of the comorbidities that we capture are based on what doctors think are important. But actually, the people we need to be asking are the patients. What comorbidities are important to them and have impact on their asthma control? So that's the first thing, sort of understanding what's important, and then formalizing it into a standard protocol of what to capture. The other bit is time, and also expertise or confidence in managing those comorbidities. If you ask about them and list them, but don't know how to do something to treat them, or whether it's important to treat them, then that's another sort of contributor, I suppose.
I have a question for you, Anna. In the simplest language possible, coming out of researcher hat for a second, what would you say to patients is the biggest thing that you personally have taken from all this research that either has changed your clinical practice, or that you would suggest that they do? Because we've already talked about that quite a bit, like patients self-advocating around getting treatment for comorbidities. But from your point of view, having done all this research, what was a big takeaway that you had for patients?
Looking at the whole patient, it's that personalized medicine. One single treatment is not going to work for everybody. So it's about that personalized approach and looking at the whole patient rather than just one blood test result or one breathing test result, and thinking about the bigger picture.
Okay. Wonderful. And to that point, someone asked in the Q&A whether you've seen anything promising for treating patients at a distance. Again, that's kind of, with your answer just now, that would involve a lot of different doctors treating patients at a distance. But have you seen anything around this in your clinic that gives you hope that that's a kind of support that patients will be able to get from home?
So I think that's a big research question at the moment. How can we support patients without them having to come to a big asthma centre? I know some of our patients travel a couple of hours to come and see us in Southampton. I appreciate that makes it much more difficult. So a lot of work is going into looking at digital support, and also moving care back into communities, so that the care comes to the patient rather than the patient having to come to the care.
Okay, good. Very good. Well, thank you so much again, Anna. We've got a lot of really positive, everyone's saying great presentations. I see hallelujah in the chat. So very excited reception to that. Thank you so much.
Well, thank you so much for having me.
All right, so we're ready to move into our next talk. And for those of you who know that there is going to be a presentation about medications on the horizon, this is it. So I know that we've already been talking about a number of different topics, and you're probably a little antsy, but we've just got 40 plus more minutes. So so just bear with us. And I think you're going to learn a lot in this next session about new inhaled medications coming, new biologics. I know for me personally, biologics haven't worked that well on me so far, so I'm always keen to know what's coming. So I would imagine some of you are in the same situation. So this next talk is a video presentation by Professor Florence. She is a pulmonologist in research at the University of Liège in Belgium. Her research focuses on airway inflammation, asthma phenotyping, and biomarkers to guide precision medicine. She has leadership roles in the Belgian Respiratory Society and also co-chairs the SHARP Clinical Research Collaboration. So I work with her closely, and she's wonderful and brilliant. And we're so grateful that she was able to record this talk. She's going to land and jump onto the Q&A. She's going to land at the airport. She's on a flight right now and do the Q&A with us live. So we're grateful to her dedication. And we're going to go ahead and start the video now. Thanks.
Good morning, everyone. First of all, I would like to thank the organizers for invitation. Severe asthma can feel complicated, overwhelming, and sometimes unfair. So this session is all about bringing clarity, giving you up-to-date information, and helping you feel more confident about your treatment journey. Today, we will walk through the big questions patients often ask: how doctors choose the right treatment for each person, why timing matters when starting a medication, what new therapies are on the horizon, and how biosimilars fit into the picture. My goal is to make these topics easy to understand and to show you how research and new medications are opening more options than ever before. Most importantly, I want this to be helpful for you, whether you're living with severe asthma yourself or supporting someone who is. So feel free to listen, reflect, and take what helps you the most, and I will be happy to take questions after the talk. As you know, asthma is a chronic inflammatory disease of the airways, and 80% of the patients with severe asthma have increased type 2 inflammation. And type 2 inflammation has been shown to increase the risk of exacerbations and of lung function decline. It is responsive to systemic corticosteroids, and there is sometimes over-reliance on systemic corticosteroids by the doctors and these systemic corticosteroids can have lots of side effects. And we are now lucky to have biologicals targeting type 2 inflammation, thereby reducing the exposure of patients with severe asthma to systemic corticosteroids. So how do we identify type 2 inflammation? These are the measures we are doing in the clinic. You see that we are measuring hexane nitric oxide. If it's higher than 25 ppb, we think about type 2 asthma. We also use different lab tests, such as the eosinophil count. If they are higher than 150 per microliter, it seems that the patient has type 2 asthma. We are also able to measure specific IgE, and the search for the sensitization to ulcer mites, cats, dogs, grass pollens, tree pollens, and molds. And if a patient is sensitized to common perennial allergens, then it means that probably there is type 2 inflammation. We can also use induced sputum, and we are counting the cells in the sputum, and if eosinophils are higher than 3%, then it is a sign of eosinophilic inflammation, type 2 inflammation. So we are measuring these biomarkers several times. If they are never high, then it means that it is a non-type 2 asthma. And it is important to search for these biomarkers because it will give you an idea of the responsiveness to different treatments. So these are the new GINA guidelines published very recently on how we should, as a doctor, investigate and manage difficult to treat asthma in adults and adolescents. So first, of course, we have to confirm the diagnosis. This is very important to confirm the diagnosis, be sure that the symptoms are related to asthma. Then we have to look for factors contributing to symptoms, to exacerbations, and to poor quality of life. So we will check the adherence of the patient to the inhalers. We will also check the inhaler technique. And we also have to search for other diseases that are responsible to symptoms that are sometimes mimicking asthma symptoms. And these diseases are obesity that can cause dyspnea, the gastroesophageal reflux disease that can cause cough, the chronic rhinosinusitis with the postnasal drips that can also induce cough and sputum, and the obstructive sleep apnea that are contributing to poor symptom control. And if we identify this disease, we have to do our best to manage the comorbidities. So we will optimize the treatment. We can increase the dose of inhaled corticosteroids to a high dose inhaled corticosteroids plus other controllers such as long-acting beta-2 agonists. If the asthma is still in control after 3 to 6 months, then we are allowed to consider asthma as a severe asthma. If it is controlled, then we have to reduce the dose from a high dose inhaled corticosteroids to a moderate dose of inhaled corticosteroids. If the patient is still well with the moderate dose of ICS, we are really happy. If not, if the control is lost when reducing the dose from a high dose to a moderate dose of ICS, then we have to restore the previous dose to high dose, and the patient is considered as having severe asthma. So we are here at the step 5 treatment, and you see that when we are facing a patient on step 5 GINA, we are allowed, we could consider this treatment, the anti-IgE or omalizumab, anti-IL-5 mepolizumab or reslizumab, or anti-IL-5 receptor benralizumab, or the anti-IL-4 receptor alpha dupilumab, or anti-TSLP tizipilumab. These are targeted treatment biologicals that can be added to a patient that has a step 5 GINA treatment. And what is happening in the bronchiole of a patient with severe asthma when exposed to environmental triggers such as allergens, pollutants, viruses, bacteria? You see that this exposure will activate the epithelial cells. And the epithelial cells, when activated, will release molecules in the tissue, such as we called alarmins, so the TSLP, but also IL-33, IL-25, for these molecules will activate inflammation in the bronchial tree. So the TSLP will be able to activate, and IL-33 and IL-25 too, will activate the Th2 cells and the innate lymphoid cell type 2. And these cells that are present in the tissue will be able to release other cytokines, thereby increasing inflammation in the bronchial tree. And these cytokines are IL-5, but also IL-4, that will trigger the production of IgE by B cells, the IL-13 that will have an impact on the bronchial hyperresponsiveness of the muscles present in the bronchial tree, and also playing an important role in the mucus production by the globular cells in the epithelium. So this will lead to a lot of symptoms in patients living with severe asthma. And fortunately, there was the development of the targeted treatment targeting all these cytokines in red, TSLP, IL-5, IL-4, IgE, IL-13. We now have treatments to target these cytokines and stop the inflammation in the bronchial tree of these patients with type 2 high asthma. For non-type 2 asthma, we just have TSLP to target inflammation in this specific, less frequent 20% of the patients living with non-type 2 asthma. And here are all the biologicals that are now available to manage patients with severe asthma. The first that came onto the market was the anti-IgE omalizumab, and this is a very good treatment for patients living with severe allergic asthma. And as you can see here, it was shown to reduce exacerbation by 50% in those patients. We also have the anti-IL-5 mepolizumab that is considered a very good option for severe eosinophilic asthma, and it has been shown to reduce exacerbation by 58%. It is given subcutaneously, and there are auto-injector for both treatments. Anti-IL-5 reslizumab is given intravenously every month, and it was shown to reduce exacerbation by 54%. Anti-IL-5 receptor benralizumab is given subcutaneously every 2 months, and you see that this was shown to reduce exacerbation by 50% too. Then we have the anti-IL-4 receptor, dupilumab, able to reduce exacerbation by 50%, and this treatment was shown to be more effective in patients with very high level of FeNO or blood eosinophil count, as you can see here, and less effective in patients with blood eos count below 150 or FeNO below 25 ppb. Tezepelumab, the anti-TSLP, is also given subcutaneously every month. Dupilumab is given every 2 weeks subcutaneously. Tezepelumab was shown to reduce exacerbation in all patients. Whatever the type of inflammation, it will reduce exacerbation significantly as compared to placebo, with a better efficacy in type 2 disease. So when we have a patient in front of us with severe asthma, we have to measure different parameters to choose the right treatment for the right patient. So we will search for allergic symptoms. We will measure the exhaled nitric oxide. We will measure the blood eosinophil count. And according to all these data, also looking at comorbidities the patient might have, we will choose the best first option for the patient. So it is a personalized approach according to all these biomarkers. And of course, when we think about the comorbidities for these patients, we know that these biologicals that are already available for the management of severe asthma, some of them have also been reimbursed for the management of comorbidities. So if you think about chronic severe urticaria, omalizumab is also an option that will improve these comorbidities. So if a patient is combining severe asthma and chronic urticaria, I think it's a really good option to start with omalizumab. If the patient has concomitant chronic rhinosinusitis with nasal polyps, then we have several options. You see here, omalizumab is a good option. Mepolizumab is also approved for the management of nasal polyps. Same for dupilumab, and also now very recent data for tezepelumab. So we know that these treatments will improve severe asthma and the comorbidity nasal polyps. Mepolizumab has also been approved for the hypereosinophilic syndrome and EGPA. Dupilumab, the anti-IL-4 receptor, has been approved for the management of severe atopic dermatitis, eosinophilic esophagitis, and COPD. So we think that when patient has severe asthma and a comorbidity, it's really great to think about managing all the diseases with only one treatment. And that's the reason why we meet with other specialties such as dermatologists or ENT specialists to try to discuss and to try to find out the right treatment for the right patient to manage the disease, the severe asthma disease, and its comorbidity. It is also important not to wait too long before starting this treatment targeting inflammation. Of course, it depends on the reimbursement criteria in the different countries. If you think about a patient that is living with severe asthma in the UK or in Finland, for example, the patient is diagnosed with severe asthma, he has type 2 inflammation, and then unfortunately he will have exacerbations, and the doctor will give the patient systemic corticosteroids because we know that systemic corticosteroids will work very well during an exacerbation in type 2 asthma. And you see here that the patient will receive one course of systemic corticosteroids due to an exacerbation, and then probably a second course in the next month, here in the story of this patient for a new exacerbation. And type 2 inflammation is there, but due to the reimbursement criteria in a country, you can't start the biologicals after the second course of OCS because you need 3 or 4, according to the country where you live, before being eligible for the biological. So what will happen to this patient living in a country where it's not possible to start early after the second systemic corticosteroid course? The patient will receive the second course of OCS, and then it will continue with the type 2 inflammation remaining there, not controlled with the inhalers alone. And then a few months, a few years later, once again, 1, then 2, then 3 exacerbations. But then you see that the remodeling has occurred in between. And the patient will be eligible after the 3rd exacerbation for biologic initiation. But remodeling has already occurred. The biologic will do its work. You see here, no more or very lower levels of type 2 inflammation with the biologic treatment. And it will be okay for this patient. But if we had started earlier, maybe we would avoid this persistent inflammation for months or years that could lead to area remodeling. And that's what's happened in some countries where we are allowed to introduce the treatment earlier. It's the case in Belgium. We just need 2 exacerbations before starting the biologic. You see that it's the same patient living in another country where we will be able to initiate biologic earlier. You see that there will be a reduction in type 2 inflammation, and then you have better long-term outcomes. You will have a reduction in lung function decline. You will have less exacerbations if you start earlier after the second exacerbation. And then, of course, the outcomes, the long-term outcomes, could be better with an earlier strategy. So now what's coming next for the management of severe asthma? This is a slide I presented during the ERS, European Respiratory Society Congress 2 years ago. And you see that in dark blue, in the middle of the figure, you see all the biologics I just told you about, all the treatment that are already available for the management of severe asthma. In green, you see those who are in phase 3. So I will talk you about masitinib and dupilumab today. And in the in the light blue zone, you see the treatment that are in phase 2, risabrutinib, the dexpramipexole, and rademikibart I will talk you about later on in this presentation. First, I would like to start with the long-acting anti-IL-5 dupilumab. Dupilumab is an ultra-long-acting anti-IL-5. So it's, if you want, a kind of mepolizumab that you don't have to inject every month, but you could inject this treatment twice a year, so every 6 months. So it has been engineered for an enhanced binding affinity to IL-5, and it has an extended half-life. And you see here on the graph what happens for the blood eosinophil count in the placebo group in black. The black line is for the placebo group, so you see that it's a stable blood eos count over time. And what happened when you give the patient dupilumab, first dose here at baseline, and then a second dose 6 months later. You see that there was a clear reduction that was sustained over time for 6 months, and so you could give this treatment every 6 months. It was this reduction, the impact on blood eos count was maintained for 6 months. So it's really great for the future of these patients. And is it effective to give dupilumab every 6 months? This is the results of the SWIFT 1 and 2 study who evaluated the efficacy of this long-acting anti-IL-5 in patients aged more than 12 years with at least 2 exacerbations and who were treated with a regular use of medium to high dose corticosteroids for at least 3 months. And you see that there was a 58% reduction in exacerbation, so 58% reduction is really good. And the treatment was really safe, with severe adverse events occurring less often in the dupilumab group as compared to what happened in the placebo group. So it seems very safe. And so giving injections every 6 months could reduce the exacerbation by 58%, targeting IL-5. They also looked at the effectiveness, the efficacy of the treatment in patients with severe asthma alone or those combining severe asthma and chronic rhinosinusitis. And this was presented at the last ERS held in September-October 2025. You see that those patients with asthma only had a reduction by 51% in exacerbation with this treatment, while those combining severe asthma and nasal polyps had a 69% reduction in exacerbation. So it was really wonderful what happened in those patients combining severe asthma and nasal polyps. They also did a study looking at the effectiveness, efficacy of dupilumab in nasal polyps alone. And you see that patients with nasal polyps, they were really improved with dupilumab every 6 months, reducing the nasal polyp scores after 1 year treatment, and also improving smell. And I think it's really important for patients to have improved smell with the treatment when they have nasal polyps. It's really a sign that the nasal polyps blocking the nose are reduced because you recover smell, and it's really important for this patient for the quality of life too. What are the other drug candidates in development against the novel inflammatory targets that could provide additional insight into asthma pathophysiology? There are different targets. You see here the Bruton tyrosine kinase inhibitor, risabrutinib. You see the receptor is present on the B cells, neutrophils, basophils, mast cells. If you block the receptors, the Bruton tyrosine kinase inhibitor, you will inhibit the B cells and you will inhibit the production of IgE. If you block the receptor on neutrophil, basophils, and mast cells, you will inhibit the inflammatory activities of these cells. The second treatment I would like to talk to you about is the masitinib. It's a tyrosine kinase inhibitor working on mast cells. So it's inactivating the mast cells migration and activation. And we know that mast cells play a very important role in the asthma pathophysiology. The last treatment I would like to talk to you about is the dexpramipexole. And dexpramipexole has been found to reduce the maturation of eosinophils and to reduce the eosinophils in the tissue. These three treatments, risabrutinib, masitinib, and dexpramipexole, are given orally. So let's start with risabrutinib. It's a treatment that is given orally once daily. They looked at the reduction in loss of asthma control, and they found that as compared to placebo, giving risabrutinib a low dose, 800 milligram, or a high dose, 1,200 milligram, reduced the loss of asthma control by 25% for the low dose and by 36% for the higher dose. The problem was the side effects, diarrhea, that was higher in the treatment group as compared to the placebo group, and that led to treatment discontinuation in 12% of the patient. Masitinib is also given orally. You see here that is a treatment that's targeting the mast cells activity. And they gave the treatment in that study. It was a double-blind placebo control with 2 patients receiving masitinib for 1 patient receiving placebo. They looked at patients with very severe asthma. You see we are treated with high-dose inhaled corticosteroids and systemic corticosteroids with a dose of 7.5 milligram per day for at least 3 months, and who had 2 exacerbations in the last year. So these are very severe patients with a poor lung function, and they looked if giving masitinib to the patient reduced the exacerbation rate. You see here that masitinib was able to reduce the exacerbation rate by 35%. But once again, lots of side effects, the digestive side effects with vomiting, diarrhea, upper abdominal pain, nausea, and some abnormal laboratory tests. So it is in development. There are digestive side effects. It's an orally taken drug. Dexpramipexole is also a very interesting one because it was first developed for the amyotrophic lateral sclerosis. And what they found was these patients had a clear reduction in the blood eosinophil count. So they decided that it could be an option for asthma and for nasal polyps. And so they first looked at nasal polyps. This is the paper you see here on the picture A. It is a polyp. And you see all these pink points, these are eosinophils in the polyps. And what they found was that giving dexpramipexole in patients for 6 months was completely destructing the eosinophils in the tissue. You see here the figure B, these pink points, they completely disappeared. So it was really working well to reduce the infiltration of eosinophils in the tissue. And they were also able to find that eosinophils in the blood were reduced really sharply with dexpramipexole given orally twice a day. They looked at different dosage of dexpramipexole, and they compared the efficacy of the dexpramipexole to placebo. And what they found was that once again, dexpramipexole was able to reduce the blood eosinophil count, whatever the dose, but the reduction was higher for the higher dose of dexpramipexole. And here you see the placebo on the right side of the slide. The placebo line is the dark, the black line. And you see that giving dexpramipexole, especially the green line and the blue line, but also the orange line, was able to improve the lung function. For the higher dose in blue, the improvement was 200 ml for FEV1. And there were no more side effects as compared to placebo. So it is really a safe treatment according to these data. Rademikibart is a next generation anti-IL-4 receptor antibody. So it's a little bit like dupilumab. And they looked at the efficacy of rademikibart at different doses. First at baseline 600 milligram, and then every 2 weeks 300 milligram or 150 milligram, and they compare the efficacy of these treatments to placebo. What they found was that rademikibart, the anti-IL-4 receptor alpha, was able to improve lung function. So it improved the FEV1 by 230 ml for the 150 milligram dose every 2 weeks, and by 280 ml for the higher dose. And you see here on the right that this treatment was able to reduce exacerbation very significantly as compared to placebo. And there were no side effects related to the drug in that study. Last but not least, there are studies looking at inhaled biologicals. And the first one that was presented 2 years ago during the European Respiratory Society Congress was the anti-TSLP inhaled therapy. So they compared, it was a small study, 72 patients with moderate to severe asthma already receiving medium to high dose inhaled corticosteroids plus long-acting beta-2 agonist, and all the patients had type 2 inflammation with a FeNO higher than 30 ppb at randomization. They randomized the patient in different doses as compared to placebo, and what they found was that giving the anti-TSLP in an inhaler was well tolerated. There were no serious adverse events. And when they looked at the efficacy, it was able to reduce the FeNO as compared to placebo. You see the placebo arm is in green, light green. All the doses of anti-TSLP given the inhaled biologic were able to reduce the FeNO value, and also for some of them improve lung function. So there is a study ongoing with this anti-TSLP through inhalation, the Levante study, and we will see it if it's possible, but it could be that in the next 10 years, the biologicals could be given with the ICS and the long-acting beta-2 agonist through inhalation. A short point on biosimilars, because you know that the biosimilars will just come onto the market. In Belgium, two weeks ago, the use of omalizumab, the biosimilar, was approved, and we can use it now in Belgium. And we know that it's really good, I think, for the future, because it will increase the affordability of biologicals for some patients, maybe allowing to treat earlier, maybe allowing the reimbursement in countries where it is not yet available. And as a patient, you have to know that these treatment, they were studied and they were found to show the same benefits as the original biologic, same safety, same efficacy, same pharmacokinetics and immunogenicity. There are no recommendations, no guidance on biosimilars from respiratory societies such as the ERS-ATS guidelines or the GINA guidelines. They do not address the biosimilars directly. They do not differentiate between the originators and the biosimilars. But the EMA, European Medication Agency, confirmed that those biosimilars that have been approved in the EU could be interchangeable with the originators and with the other biosimilars of the same originators. The NICE also supports switching when it is clinically appropriate, but I think it's also very, very important to have a clear communication with you, with the patients, to explain, to be able to answer the questions you could have for these biosimilars. So in conclusions, I think phenotyping severe asthma is really important. Searching for the comorbidities will help to choose the right treatment for the right patients. I think we have to start the treatment at the right time to avoid remodeling, to avoid the too late asthma, to avoid systemic corticosteroid side effects. And there are a range of potential targeted pathway therapeutics that are now in the late stage development. And I think one good, it would be the ultra-long-acting NDL5, the oral treatment. Some of the oral options are really great too, and maybe in the future, the inhaled targeted treatment. And regarding the biosimilars, they offers the lower price and a comparable safety and efficacy to their originals. So I think this could be an option to open the access to the treatment to more patients. With that, I would like to thank you for your attention, and I will be happy to take questions.
Excellent. Thank you very much, Florence. I see you here. Welcome.
Thank you, and sorry for being late.
Oh, thanks a lot. Actually, we know that you were traveling, so for taking the time to answer to this Q&A session. We have to answer just for a matter of time to keep the track on time to two questions potentially. I already see a lot of questions in the chat, so I'll try to select say a few of them, and I know already Elsa and Venetica are answering to the others. So a question is there further data on tezepelumab in OCS-dependent patients?
The data are coming, and it's promising. So it seems to be efficacious in corticodependent patient too. And I think the main reason why the first studies were negative is that it's more difficult now to find out, to identify corticodependent patients for these studies. So it's more difficult, and it will become more difficult for the next generation biologicals to show this effect, this impact in OCS-dependent patients, because those patients become more infrequently encountered in the clinic, in the routine clinical practice. So it's more difficult to recruit these patients for the studies.
Which is actually good for us and for the
patients. Yeah, it is great. It is great.
Absolutely. And that's a question that I saw actually quite a few times. So I think it's worth to clarify if how biologics affect the immune system. Some patients might be afraid to have a higher risk of infections.
Yeah, we know that with some biologics, such as for dupilumab, for example, some vaccines are, it's sometimes not recommended to use some vaccines in the patient because of this reduction in the immune system. So I think, you always have when you are treated with a biological, you have to discuss with your doctor regarding the different vaccines. And regarding infections, that's true that there were in most of the biological studies a little bit higher risk of nasopharyngitis or other infectious disease, but it's really non-severe infections, and it's more protective against exacerbation than the risk of having infection. So I think when you put everything in the balance, it's clear that the biologic treatment offers a protection against exacerbations. That I don't know if you agree with that, Stefania, but I think it's when you put everything in the balance, that's true that sometimes it could be a little bit higher risk of having nasopharyngitis, but I think it's really protective against these infections too. And exacerbation and requirement of systemic corticosteroids when you are sick. So I think it's really helpful more than it hurts.
Absolutely. I don't know, Hilary, is there anything you would like to add?
No, thank you for the invitation and for the questions and interactions. And if there are other questions, I will be happy to answer that with a writing answer if you want.
I was just going to say, we only have about 8 more minutes, so we're going to start to wrap up. But I just want to thank you again, Florence. In the chat, we saw so many messages that said, this doctor's so knowledgeable, this is amazing, there's so many medications coming, I had no idea. But, you know, people very excited. Someone asked what biosimilars are. I'm going to answer that because it's one sentence. They're basically generics for biologics. And they're now that patents are starting to run out because biologics have existed for long enough. All these great biosimilars are coming. So that's exciting. As Florence said, we're going to be answering a bunch of your questions offline after this, any ones that didn't get answered. So you'll be able to find those on the European Lung Foundation website. So now we're going to just close out. Can I get those slides up about Sharp, please? Thank you so much, Claire. So I just wanted everybody to know that Sharp sponsored this event. It's the wonderful research consortium that Ramesh, Anna, and Florence all work with. Can I go to the next slide? So thank you, Sharp, for sponsoring this. Sharp was founded in 2017 to improve severe asthma care across Europe. Next slide. So what Sharp does is there is a community of, it's now 280 patients, clinicians, researchers, and pharmaceutical partners from 28 countries across Europe. We collect data on patients for researchers to use to improve medication, to learn about severe asthma. We have a bunch of articles that have been published in peer-reviewed papers, a lot of abstracts pending, and several ongoing projects. We believe very strongly in giving patients a strong voice, and we're working right now on different frameworks like a clinical protocol that'll help all doctors start to ask the same questions. This is our big goal for the future. How can we get doctors to ask the same questions so we can all be learning about, so that they can give consistent treatment to severe asthma and we can learn about it as much as possible. Can I go to the next slide, please? Thank you so much. So again, what makes Sharp unique is we involve patients in everything we do. We have 2 of the largest severe asthma registries in the world, and we're the only severe asthma research group affiliated with the European Respiratory Society. So when I say we involve patients in everything we do, it's really true. We've got Betty here and Luciana, who I think are on the conference right now. They're wonderful. There's a patient co-chair. That's me, the patient advocacy group. We meet every month. Sometimes we have people come to the meeting to ask us questions or to get us involved in research or to tell us about clinical trials. Several of our patients have been listed on co-authors, which is very cool. I mean, it's co-authors on papers, which is very cool because sometimes they're for journals like The Lancet and European Respiratory Journal, and it's amazing to see that patient voice there. It's so important. So we really believe that patients' input is critical at every step for understanding socioeconomic barriers, quality of life barriers, how it impacts you and your family, and so on. When I say we have 2 of the largest severe asthma registries in the world, what I mean is we have data from 14,000 patients, And researchers all over Europe use that to do all kinds of research, much of which looks exactly like what Anna presented earlier on comorbidities. And we have severe asthma leaders from all over Europe keeping an eye on this and involving as many clinics as possible. So you probably have a severe asthma leader collecting that data in your country and don't even realize it. I didn't before I joined Sharp. Can I go to the next slide? And the final is just to reiterate that we are the only research consortium within the European Respiratory Society. So that's wonderful because that gives us terrific access to the 35,000 respiratory clinicians and researchers in the network. And we also work very closely with the European Lung Foundation. So thank you so much again to all the wonderful staff at the European Lung Foundation who led today and spent their Saturday hosting our Zoom and making sure that we were all supported. Again, if you want to get involved, you can email we'll put the email in the chat that you can email to join the patient advocacy group. And now I think we have just a couple slides on European Lung Foundation. Is that correct? Or sorry, Paul. Sorry, Stefania, I'm turning it over to you.
Oh, yeah. So we started with a poll at the beginning. I'm very curious how is going to be the result of this poll in the end. After today's event, how much do you know about severe asthma? And you can vote from 0, which is completely no knowledge, or 10, which is extremely knowledgeable. And thank you all for the very nice comments that we see in the chat. That increased quite a lot among before the majority was around 6, 7, a few 8, 9, and now we see a big escalation. I think we had really a lot to learn. I had to sum up take-home messages. I wrote 2 pages of take-home messages for how many topics we touched upon. I want to thank you, Hilary, for co-chairing with me. And thank you, everyone. Please sign up to the ELF newsletter, get involved, emailing us. You can also find information on severe asthma and many other related topics on the website. So I think that really knowledge is power, and that's the main message that I'm taking away from this event. And it's a power both for patient and for clinician. And we can, definitely with this type of events make use of this in the best way to really find together a common path. And I don't know, Hilary, if you have anything else that you would like to add.
Yes, I mean, I think my big takeaway is that patients are really passionate about and capable of understanding very high level material, exactly like I said at the beginning. These were complex topics today, and everybody followed along beautifully. So thank you so much for your attention and your time. I want to give a final thank you to Ramesh, Anna, and Florence, who were all wonderful, Sven, Eric, and Els with the Q&A, the Asthma Advisory Group, all the Sharp researchers, clinicians, partners, ELF, staff team, everyone who shared today's event and helped promote it. And of course, my wonderful co-chair, Stefania. One last time, if you want to learn about the PAG, the email is in the chat. And a reminder that today's talk was recorded. You'll be getting that in a few weeks. Because we need to do the transcript for it, just to explain why it takes a little time. There will be a short feedback form sent out to everybody. So please fill that out so we know what you think and what we can do better next time. And we're exactly on time, 1:15. Thank you so much to everyone and take care. Bye-bye.
See you soon. Bye-bye.